All right, welcome everybody. Today we're going to talk about substance use disorder and behavioral addictions. I'll be curious to know what your interaction is with this because it turns out that this is probably every family has someone in it that may not be known to others. And the reason you find that out is when they come to care, they almost whisper it sometimes, or they tell you about the household that they grew up in where it was going on and nobody knew, and everyone thought that this thing was under control. But it also complicates a lot of psychiatric diagnosis. So, for that reason, it's going to be helpful to really understand what seems to make up a large portion of patients who come for psychiatric mental health. So, by the end of this, I want you to feel confident, at least looking into these, asking complex questions, delving into some of these cases, and to apply some of the skills that we learned last week. Specifically, we'll review again motivational interviewing and relapse prevention as it specifically applies to this lecture. Does anyone have any questions? Oh, if you have questions or when I call on you, what I need you to do is to raise your hand. We're using the hand icon so I can see who you are because it doesn't automatically default to you. So when you ask a question, please use the hand raising icon, okay? Any questions about what we're going to do today? None. All right, so let's get into this then. So substance use disorders affect almost 50 million people in the United States. And if you think about the prevalence of diabetes, think about how many people you've encountered in your career with diabetes. Now, realize that those with substance use disorder outnumber them. To give you an idea of how prevalent this is. The other thing that we need to talk about is behavioral addictions. The only behavioral addiction that has made it into the DSM is gambling addiction, and we'll talk about that. But you can clearly think about other behaviors that people may be addicted to that have not yet made it into the DSM, but is definitely causing a distress in multiple domains of life. And then the other thing we definitely have to talk about is this whole concept of dual diagnosis, where it's not enough to just treat the addiction or the underlying mental disorder. There is better evidence to treat both of them at the same time. So, what is your experience thus far with clinical addiction or substances or behaviors? What have you noticed either in your own clinical practice or previously? Natalia,
Pain medications.
addiction to pain medication. So oftentimes it's interesting, the opioid epidemic, a large portion of it was started out of prescription, well intended. No one sets out to be an addict, by the way. And that's something else we'll talk about as we get into, as we get deeper into this. Yes, go ahead, Bellum.
Yeah, my experience has been that it's quite complicated and that it I've found it virtually impossible to help people with substance use disorder because there usually is this dual diagnosis of mental health issues that have long gone untreated. So it gets so complicated, it's very difficult.
Right. Erin, what's your experience?
My experience was most notably ER, acute alcohol or withdrawal, as well as some benzos, which could be quite serious. It would put them in the hot spot of the ER.
Yeah. Bogdan, did you have something?
I was going to say exactly what Aaron said, that in the emergency room, I've had experience with many alcoholic withdrawals and addictions, and as well as the benzodiazepines. And I did realize that with alcohol, a lot of my patients that are admitted for withdrawal symptoms, they most times they come back again in the future and they're readmitted for the same exact substance abuse, regardless of any teaching that we provide them.
Yeah, Yeah. Evgeny, what do you got?
So I deal with the large homeless population, and a lot of these people are very honest in the sense that they don't want treatment. They are very happy being addicted and doing drugs, and a lot of the commonalities is they can't wait to get discharged from psych just so that they can go back and use drugs.
Mhm. I think happy might be the wrong word, but I think comfortable in their present state might be more apropos. I don't think people set out to be addicted to something where it's all they think about and live for, essentially. Abigail, and then Irina, and then Christine.
I feel like a lot of the patients that I see will end up going into status epilepticus. So we get a lot of like alcohol withdrawal patients where I work, and they'll try to stop on their own. They end up seizing from alcohol withdrawal. And well, once they're extubated and stuff, a lot of them will tell us that they don't want to be discharged unless it's to some sort of addiction clinic, because they know that when they leave, they're going to end up going home and drinking. So they kind of like get stuck in limbo, like waiting in the hospital for placement at a clinic that will take them.
Irina, and then Christine.
I work in liver transplant, and what we see with our patients who are actually highly motivated to not go back to drinking after their transplant, there's a lot of things that neither they nor we can control. And the biggest thing is that they go to the same home where they came from, to the same 20 years of dysfunction in the family, in their life.
You're raising a very good point about the background and the environment to which people return to.
And of course, prior to transplant, the family knows all the right things to say. It's like, of course, we're not going to have alcohol in the house. Of course, we're going to support him. Of course, this, and the other thing. But all the dysfunction that's been going on for the past God knows how many years, that's not going anywhere just because now this patient's motivated. Not always, but oftentimes.
Christine? No? Okay. Okay.
I didn't realize I was on mute.
Go ahead.
Similar to what Irina and Abigail had mentioned, I find that social determinants of health can be confounding for this population. At least, like, I work in an inpatient psychiatric facility unit, and what I find is difficult is that there may be people who would be motivated. However, if they're returning to the streets, I understand our social workers had mentioned that you have to have actually like fatally used or are in like a certain usage from when you get admitted to rehab in order to get admitted. There's like some kind of requirement for when you actually use the substances. Well, then what we find is that people will use this kind of like as a secondary method in order to get housing and not necessarily because they're rightfully addicted.
Good. You're getting to a lot of key points that we've discussed in previous weeks. Why do you think that substance use disorders go undiagnosed in certain populations, like, say, the elderly? Write your thoughts in the chat, and we'll get to them. Okay. Put your thoughts in the chat as to why do you think certain populations go undiagnosed? So you alluded to something very good about, maybe that's not about the addiction, but we're doing it to get something else. And so I'm just going to review this 6-step process here with respect to making a psychiatric diagnosis. Step 1, you remember from last week, was to rule out factitious and malingering. And you know that factitious is essentially valuing being in the sick role, whereas malingering is distinguished by external motivations. And so the external motivation could be something like housing or access to some sort of a benefit program or something to that effect. Then step 2, before you land on a primary psychiatric diagnosis, would be to rule out a substance-induced condition. And that is what the thrust of what we're going to be talking about today will be, is this substance-induced as a condition, this polysubstance use or substance use disorders. But that may be, as you will see, the reason for those behavioral symptoms that are causing them to come to care. And then step 3 is rule out an underlying medical condition, and we'll talk about that next week. And then, of course, adjustment disorders. This is where it's causing distress, but on some level, it may be a normal reaction to a stressful situation. But by definition, we expect most adjustment disorders to resolve on their own in about 6 months. And then we decide on the primary psychiatric disorder. And of course, we need to distinguish between eccentricity, oddly related, and what is truly a mental disorder versus, well, that's just what makes you special. And so we don't want to over-pathologize, because the danger in psychiatry is these diagnoses are very sticky and they're hard to undo. So a big temptation that needs to be overcome is jumping to a diagnostic conclusion. It's better to leave it open and name the symptoms than to apply a very sticky label with not enough information. So we're going to go through and we're going to apply the biopsychosocial framework to substance use and behavior disorders. And for the purpose of this lecture, when you're addicted to a behavior, I'm just going to call that a process disorder. And when you are addicted to any substance, that will be substance use disorder. Okay, so the biopsychosocial model will look at biological, genetic, say, social, and psychological factors that lead to you that may set the stage for you to come to care. Now, this is very important, because when they come to care, you may really want to help them, but there's no way to really put the eggs back in the shell. And for that reason, I want to reiterate the fact that your interventions are going to primarily be aimed at the perpetuating factors. So what I want you to think about now is, can you share an example in someone with a substance use or process disorder where you can identify some precipitating and also some protective factors? Now, keep in mind, none of these addictions developed overnight. This addiction did not happen because someone used something just one time and then forevermore it followed. There is a lot that goes on in the environment, in the psychology, to allow an addiction to develop. So think about that when you think about some of the precipitating and protective factors related to substance use disorder. Natalia, go ahead.
I think this is family, significant ones, friends. That can be a perpetuation factor, but it also can be protecting, opposite can be protective factor.
That's interesting. So the family could be the psychological predisposing factor, but it sometimes can also be a protective factor. That's a very good observation. What I'm looking for from someone is, tell me what you think some precipitating factors are. Why now? That's the question you're trying to answer, is why is this day more special than any other that now you decided it's time for you to come to care? Because this addiction has not just been going on for 1 day, 2 days, or even a week. This has been going on typically for months to years. Vilma.
I remember reading about this singer who is named Tina Marie. I don't know if you know who that is, anybody knows who that is, but Tina Marie, who was married to Rick James, anyway, or was friends. Anyway, when Rick James died, they were sort of like best friends for many decades. And when he died, she had a back injury that she was taking opioid pills for. She said that when he died, her emotional pain was so bad, she didn't realize that she was suffering, but that the pain pills made that go away too. So she became addicted because of that, even though she didn't start out taking them for her emotional pain.
Mm-hmm, mm-hmm. Yeah, you don't realize medicating one thing with another thing. Mm-hmm. Let me hear from Irina, then Samantha, and then Kira. And then we'll go on.
I just want to clarify the question. Are you asking like what leads to them seeking care, like when you meet the patient, right?
Right. Why today? Why now are you coming for care when this has obviously been going on for many months or years?
Right. So I think, again, and I'm relying a lot on my experience from work. It's something really bad happens. So either they get really sick or they get in a bad car accident, or they hurt somebody, or the court makes them come in, right? Something that's like just something dramatic outside of the normal, that they kind of have a come to Jesus moment.
Okay. And what about a perpetuating factor?
Perpetuating.
Like, I'm sorry, the protective factor. What is the protective factors?
I think protective factors is like how well their life is set up. So someone, for example, with a good job will have a kind of imperative to, you know, clean up and not drink in the morning and show up to work like in decent state, you know, or if they have a family to provide for, something like that, or maintain a relationship that they're invested in.
What do you think about that, Samantha, the protective factors that Irina just mentioned? Job, a family, reason to stay sober. What do you think about that?
So I work on an adolescent unit, and I was going to say a lot of times our patients will come in like brought in by like their parents. A lot of them will be like using marijuana and will have like psychosis for the first time, so that will bring them in. But they'll like their protective factors will usually be like their friends, but their friends are usually the ones who are like providing the marijuana or the ones who like they're smoking with.
Right.
So for my population, a lot of times like their protective factors are actually like hurting them. So, but like for adults.
So
like,
why would you still call them protective factors if they're hurting them? They might become perpetuating factors.
Yeah, well, when they do like this safety plan for discharge, you know, they ask them what are your protective factors, and a lot of times they'll say they're friends, but like from our point of view, it would be more of like a perpetuating factor than a protective
Right.
factor.
I agree with that, but the thing is, we're not just filling out a form, right? So it would be nice when they say, oh, my friends are the protective factor. You mean the same friends that introduced you to this drugs and alcohol that you've been doing? We're not writing that down as a protective factor. And you might want to think about that as a teaching moment to say, no, they're not protective, they're perpetuating. A protective factor would be something that keeps you from doing this. What is it that keeps you from doing this? And so you may want to use this biopsychosocial framework with the 5 Ps as a teaching jumping off point. Let me hear from Kiara and then Theo, and then we're going on.
Just to give an example from my job, we have a client who, an elderly man in his 70s, he had started experiencing increased falls in his home, which is, you know, fairly common in older people. But it was through talking with him and trying to figure out why the falls were happening that he disclosed to us that he was overtaking his Ambien and drinking alcohol at night to go to sleep. So he was just over medicated and really unstable, and that's what was affecting his gait and was contributing to his falls while he was at home. But I had known him for probably a year at that point, and I had no idea. He had never disclosed to me that he was abusing. I knew he drank, but I didn't know he was abusing the Ambien, and the combination of the two plus the falls was what kind of gave him, I guess, that motivation to open up about it. He's still doing those things, but we're working with him. I guess that's sort of a protective factor, is like what our program does to kind of support him and exercise harm reduction. Yeah, that's what I got.
Great. Let's go on. Okay, so you can see here that the epidemiology of this condition is that it basically outpaces diabetes. About 37.3 million with diabetes compared to 48.7 million with a substance use disorder. So it's to just put it in perspective as to the sheer number. And why this is helpful is sometimes it's helpful to point out you're not the only one. There are so many people struggling with this. And it's interesting because, you know, someone had mentioned that occupation can be a protective factor. Well, it may be, but there are a lot of high-functioning alcoholics and drug-addicted people in professional fields working essentially what they call flying under the radar or functional alcoholic types. How many of those coffee mugs that you see in the morning might be having more than just coffee in them? Or how many of those water bottles may not just be water? Because if the numbers are to be believed, and it's truly this high, it might help you put it into perspective to realize how prevalent this condition is. And then if you look at something like the pandemic, where the phrase daytime drinking became popular again, people drinking throughout the day. So a lot of people, interestingly enough, seem to have spurred or developed this maybe later in life. It's not uncommon. I mean, it's more common to develop if you start earlier in life, but it is not uncommon for elderly people to start this after a major life crisis, to start drinking, to quote, take the edge off. So substance use disorders and behavioral addictions tend to stem from a few things. And you had mentioned this before in terms of your population of liver transplants and essentially going back to the same environment. If you go back to the environment that allowed this addiction to develop, there's a really strong chance that this addiction is going to relapse, fulminate, and continue and perhaps worsen. This behavioral addiction stems from drug availability, sometimes a genetic predisposition, could be trauma, could be peer pressure. And it's interesting because, you know, when people use, be it cigarettes or alcohol or whatever, it comes with a whole ritual alongside of it. I smoke with my friends at the bar, I drink with so-and-so, etc. So then when you tell them you need to abstain from this, one of the biggest problems, they're going to say, well, I have to give up my friends then. What am I going to do now? And so you're not just removing the addiction, you're also changing the pattern and the environment that allows it to ensue. And they may never have known how to socialize or meet other people without the substance on board. And that's particularly becoming common now with the ubiquity of marijuana. So the other thing we'll talk about are some comorbidities that tend to occur. What are some comorbidities? Name one that you've seen in your practice and how it impacts treatment for, say, a substance use disorder. You can put that in the chat, actually. Think about the comorbidities that can occur alongside or as a result of a substance use disorder, and how might that affect treatment? So we have a few theories we need to talk about. The modern theory now is primarily driven around the neurobiological theories, but when you're talking about psychotherapy, the classic theories are still in play, even if we say these have been dispensed with. So early theories of addiction were essentially, these are masturbatory equivalents, essentially defense mechanisms against anxious impulses, oral regressions, or a disturbed ego function. You have an inability to deal with reality, and so therefore you're self-medicating. And so what happens is people almost know this when they come into therapy, and I've had patients start with, I'm not medicating anything, I just really like it. So early theories compared addiction and heroin rush to things like orgasm. It viewed the substance use as an anxiety coping mechanism linked to developmental issues. And they may have little relevance, but I think in the psychodynamic world, they probably are still very much in play, because I don't think this is purely a biological condition. Because just because you're genetically predisposed, access to the substance is still required. So it's something to keep in mind. And I think that it's much more complicated than just a psychological or a biological. I think a both-and approach is necessary. I was going to ask you, why do you think these older theories fell out of favor? Depending on your political leanings and what you do with your understanding of the current climate, that may determine what your answer would be. Suffice it to say, times change, theories change. The DSM has changed as to what constitutes a mental disorder. So it's not merely a political agenda. Just the mores of the day have also changed. I mean, if you think about back to when we had in this country prohibition and to where we've come to now. So a lot of factors affect what we're calling a disorder. So the modern neurobiological understanding is addiction involves binge and intoxication arising in the basal ganglia. That's where that takes place, the drive essentially. And then we have withdrawal negative effects, which causes this fear-like state extending into the amygdala. And then we have preoccupation and anticipation, and that's the involvement of the prefrontal cortex. And so this is why some of the questions you ask in your screening would be, well, how much time do you think about getting high? Or how much time and energy do you spend in acquiring the substance or engaging in the substance? What have you given up, if anything, to pursue it? That's one set of questions. That's dealing with the prefrontal cortex. But another set of questions is what happens when you don't take it? And what you're really getting at there is, are you truly having a withdrawal picture? Is there truly a physical dependence? And so that's where you get stuck on the amygdala portion of the response. And so those are what your questions are like. So this cycle explains why patients may struggle to stop despite consequences. I'm curious what you think the hardest stage is for patients to break. What's the hardest, do you think? The binge intoxication reward, the withdrawal, the preoccupation? Oh, and also let me just put this other piece in there. So when this happens over months to years, a neuroadaptation of the brain is occurring. So that's something else to think about, because it's not just the physiological piece. There becomes this habituation of the social and environmental factors. You keep doing the same thing. You keep going to the same place. You keep avoiding in the same manner, etc. What stage do you think is hardest to break? Go ahead, Erin.
Sorry. I think probably the last stage, the preoccupation and anticipation.
Why?
Because I think it requires the most work, constant maintenance and life. So stressors are going to come up, triggers.
Natalie?
I think, yeah, I agree. I think it's the preoccupation anticipation phase, just because, like, our dopamine is like linked to our motivation as well. So sometimes, if we're reminded of like certain things of our addiction, then like we feel a rush of dopamine and we're more likely to want to engage, even if it's not the actual drug that we're of choice. So like things were around. So like even if like friends remind you of certain like drugs that you're doing, things like that can. So yeah, just like the motivation and the dopamine aspect of when we're about to get the reward or when we're close to achieving the reward, it kind of motivates us to then get that rush again, even if in small doses. And like the more likely we are to like feel the dose, like we grow a tolerance to it and then we like keep going after it.
Hyla? No? Okay.
Oh,
All right.
okay. Am I in? Okay.
Go ahead. Yeah, go.
I think it was the if you go back, I get the second phase, the what was it called again? The negative effects. Oh yeah, the withdrawal. Yeah, I would think it's the withdrawal negative effect stage, just because, as you mentioned before, people have friends and family they drink with, like their whole life is set up around this behavior, and unless they have, and it takes time to, again, make new friends, find a new environment, like you really have to make major changes, and until those changes take effect, you're going to feel it. You can't drink with the same buddies anymore. You can't go to the same places. You can't, so I would think that the negative effects stage is the most difficult, because it does take time to make all those adjustments.
So the basal ganglia drives the reward and habits, extending to the amygdala which handles stress and withdrawal. And then the prefrontal cortex governs decision-making. Dysfunction in these areas is where some research is now aiming to think about how we can target treatments. So it's interesting, but if you think about this prefrontal cortex, that is the most complicated, most cerebral, that's the top-down approach. But if you look at most addiction treatment programs, detox programs, they tend to do this bottom-up approach because on some level, so I have a patient that I saw today again, but I've only seen this patient intoxicated because she only sees me for detox. Well, if I'm only seeing her when she's intoxicated to the point where she's needing a detox, that's not exactly the time where I can enter into a prefrontal cortex discussion with her about life changes and habits and environment. But she is only engaging me for crisis. And then when it's better and she feels better by day 3 or day 4, I got this. I'm going to do my thing. I'm not going to stop. I can control it this time. So it's helpful if whoever's encountering the patient can appreciate where they are so that the treatment can be tailored. So from a crisis intervention perspective, I'm just trying to mitigate the withdrawal symptoms. But hopefully someone can catch her, say, on day 5 or 6, and we can start to get her to engage into movement. And then hopefully at some point she will establish some sort of habit where she's willing to engage in a more cerebral manner. So this here is a picture of the dopamine pathways in addiction. The mesolimbic dopamine pathway leading to the ventral tegmental area and to the nucleus accumbens and eventually to the prefrontal cortex. These components are what make up the reward highway. All addictive substances spike dopamine in this pathway. So when you know that, you realize it just doesn't have to be like a line of cocaine. Anything that causes this reward pathway can do it. So you can now appreciate why behaviors can become addictive. So for example, if you're a workaholic and you're really good at it and you get rewarded a lot at work, you may continue to do that to the exclusion of multiple areas of your life. You may forego eating, sleeping, your family relationships, etc. And we call you a workaholic, but when you live in an environment that rewards that, say New York City, it gets really hard to tell someone this is not working out well for you. And then, of course, what happens is your tolerance for this goes up. I'm thinking of my first-year analysts here at the major investment banks. Some of them turn to drugs and alcohol and gambling. Some burn out, drop out, move on to something else. But others really relish this and do quite well when they figure out how to create a balance in their life. Sometimes it's just situational. They say, this is a phase. I'm doing it for a year or 2. It will get better over time. The other theory here now about addiction is this structure called the lateral habenula. This is the brain's anti-reward center. And this goes back to that singer you were talking about who turns out was medicating the distress and the physical pain, or the pain that was made physical by the death of her significant other. But the lateral habenula functions as a critical negative feedback system in the brain's reward circuitry. So you need to think of this as the neurobiological, quote, reality check that keeps the dopamine systems balanced. The normal function of this habenula is in reward monitoring. When expected rewards don't materialize, this lateral habenula activates and inhibits the ventral tegmental area where the dopamine neurons are. If you have disappointment, it essentially tells the brain that didn't work out as expected. And then you develop a behavioral adaptation to promote learning from the negative outcomes, and you develop, hopefully, behavioral flexibility. That's if it's working properly. But if it's not working properly, there's a pathological shift. In the addiction, the lateral habenula becomes hyperactive during withdrawal states. And instead of balancing the reward processing, it creates a negative feedback loop. It's an amplified aversion. It makes withdrawal more unbearable than it should be neurobiologically. So then what happens is people develop this compulsive compensation. This drives the individual to use substances just to silence this anti-reward signal. So how might this manifest? Well, these are the symptoms that we may label either dual diagnosis or treatment resistant, but you may notice symptoms as a result, such as anhedonia. I can't get pleasure from anything other than this thing, or stress amplification. Everyday stressors become magnified, or withdrawal hypersensitivity. The normal discomfort just becomes so unbearable, or compulsive seeking behaviors where drug use becomes less about pleasure and more about escaping this habenular driven misery that they have now experienced. Withdrawal is very different for everybody. And interestingly enough, not everybody that has dependence develops withdrawal symptoms. Now, the other thing I want to make sure we distinguish here is, can someone tell me the difference between dependence and addiction? What's the difference between dependence and addiction? Is it the same thing? Dependence and addiction are the same thing? Or is there a difference? Vilma?
Dependence is physical. Like dependence is physical, like coffee, like caffeine. Like I get a headache when I don't drink caffeine, but I'm not like addicted to caffeine. I'm not like so looking forward to it. I can't wait for it. It's like, it's just that if I don't drink it, I get a headache. Is that?
You're partly in the right direction, Irina.
Addiction is needing more of the same substance to achieve effect. I'm sorry, not the other way. Dependence is needing more of the same some substance to achieve the desired effect. But addiction is when you keep using even though it is negatively affecting your life.
You're partly right, because based on your definition, then I would ask you, how would you define tolerance then? So now we have three terms.
I'm sorry. You're right. I said tolerance.
Dependent and addiction, right? So what you described was tolerance, right?
Yes.
I need more and more to achieve less and less, essentially. That's tolerance. But what is dependence?
Dependence, I guess you get...
Natalie, let me hear from Natalia. Natalia, what is dependence and how do you distinguish it from addiction?
Dependence is physical reliance on substance or alcohol. It's tolerance develops and withdrawal takes place. Addiction is compulsive drug seeking, used despite negative consequences. But dependence doesn't include addiction. Doesn't mean it's the patient is addicted. But
that's
addiction,
exactly right.
Patient with addiction is dependent.
So you're exactly right. So dependence, by definition, means that you will have some withdrawal symptoms. So if I don't have my coffee by a certain time, I get irritable and I get a headache. I'm dependent. But I wouldn't say I'm addicted in that I'm not having the negative consequences where I'm committing crimes or putting my whole life on hold or neglecting relationships or not going to work, et cetera, et cetera, et cetera. So that would be a way to understand the difference. So tolerance, you need more and more just to achieve the same level. The dependence comes with physiologic withdrawal symptoms, and addiction is the psychological component where you continue despite consequences. So it's helpful to clarify those terms in your mind. You might see them somewhere. Now, I uploaded to you that interview with Anna Lemke. She's this psychiatrist from Stanford, and she describes this seesaw model that shows how chronic pleasure drug use tips the brain's dopamine balance, causing pain during withdrawal as the brain seeks homeostasis. And so that's the tolerance where I just need to get it just to feel normal. I'm not even doing this to be high anymore. I just want to feel normal. And so this may explain the cravings and why recovery takes time. So how might you apply this model to something like, say, social media or video gaming? No, can't apply? Okay. Go ahead, Natalia.
It could be like just checking your phone, not purposefully, so not intentionally, and just for social media purposes, like not actively going to actually message somebody or like have a purpose, just to check on it out of habit. So it's like a behavioral, and like it's a behavioral thing that it's because your brain wants to, like it's habitual. So essentially you just keep going on it, and it does give you a dopamine hit. But like you said, it's like you're tolerant of it. You're not really actively seekingly something.
Right. Velma?
Maybe like a gradual withdrawal that's very controlled so that you don't experience this like extreme seesaw.
That's interesting. So you're recommending it as a therapy. So like, let's wean the social media rather than just cut it off all at once.
If
You're
you,
gonna be, yeah.
if you can control it, like if you can have some outside control so that like
that's a really interesting thing, because when I deal with parents and their teenage kids in the social media situation, what they say to me is that's their only place for socialization. That's the only way they can talk to their friends. Otherwise, they'll be very lonely. And so they try to do that with varying degrees of success, because essentially what you're asking for is someone to put a boundary where none existed before. And they may not have experience in putting in boundaries. They certainly don't have experience in enforcing them. And the other person saying, what's a boundary? So that's an interesting way to approach it. So the other thing to look at here is her work shows that digital behaviors like gaming or social media tend to hijack the same reward pathway as substances, leading to tolerance and withdrawal. Just do a little experiment with yourself where you just basically put your phone away for 24 to 48 hours and see what sensations come up in your body. What do you feel? How often do you go to check for it? Do you have a phantom vibration pain or a phantom vibration signal where you think, I just heard a message? Do you randomly just hear audio hallucinations of, did someone text me? Did I hear a chime? Was it a ping? How much of that do you think you're going to do? So the reason I bring this up is because it's always important to remember to screen for a behavioral addiction alongside the substance use. One popular example, say, when we talk about overeating or binge eating, etc. So what you might find is someone will say, oh, I want to lose weight. I can't stop eating. I'm eating too much, etc., etc. Well, what happens is everyone tends to focus on the eating. So here's the nutritionist and the Weight Watchers and the eat less and the move more, and they give you that standard spiel. But what we forget to assess for is what goes on around the eating. Tell me where you're eating, how you access it, what you do. And what you find out is, well, I come home and I sit on the couch, I flip on the television and finish the bag of Doritos. Interesting. So if you take a very simplistic approach, you're just focused on the Doritos. But what you might need to do at the same time is focus on the television watching and that passivity where it hypnotizes and allows you to kind of mindlessly do it. So it's interesting to look for the behavioral addiction alongside. Also, the thing to think about is to notice if you've noticed patients switching between substances and behaviors. Velma.
I'm in a program with Gabor Mate for trauma therapy. And the way that they approach addiction is asking, what does the addiction do for you? And just kind of exploring assuming and expecting that this has a very positive component for the person, also the negative component, but that it's doing something really helpful.
No, that's a very good way to approach all of the symptomatology that comes up in psychiatry. What you're asking essentially is, what does this condition allow to happen, or what does it prevent from happening? And you will find patients dancing all around that question because they're not quite ready to face that answer. And so we would rather just stay here for now because it's comfortable, it's familiar. One interesting thing to keep in mind, and this came up today in a conversation, when you're entering a relationship or you're about to do something and you say, oh, we have good chemistry. Well, good chemistry really just means familiarity. Why aren't you put off by this? If I were to ask you 5 years ago, and here we are now, what line would you have never crossed? And then you find by the time they come to treatment, they've crossed all the lines in their minds. I will never do this. I will never do that. Then you find that gradually that erodes over time, and people will do almost anything to feed that addiction because the reality may be so unbearable, or at least perceived as unbearable. And there we are again, pulling from those classic theories. So dopamine drives reward. GABA inhibits it. So if you took the psychopharm class, you know that GABA is the inhibitory neurotransmitter, and that's typically targeted by things like alcohol and benzos and opioids, and they mediate pleasure. So what happens is you can develop this cross tolerance to a variety of similar substances, which may make the withdrawal picture so much more intense. As you understand how cross-tolerance and genetic and environmental variables play into it, you may now be able to think about more targeted treatments. So for example, you might offer medication-assisted therapy. That might mean Suboxone for opioids, or gabapentin, or naltrexone for alcohol use disorder. These are things where you're targeting the reward pathway, but you're capitalizing on these cross tolerance if you're going to withdraw them. So one of the things you may notice is in the old days, there used to be a drug called phenobarbital. And phenobarbital was nice because it was a very long half-life. And so when you're trying to get somebody off of, say, alcohol and the benzo's not working, we used to use phenobarb. And you would give them somewhat large doses in the first few days, because what you were doing is you were capitalizing on the tail, on the long time it takes to metabolize that drug out. So if I'm having a hard time getting someone off of alcohol with Valium, phenobarb is something that I may look at. The problem is it's so old that it's sometimes not always in the pharmacy, and it might take days to get. So just something to keep in mind. So substance use disorders have about a 40 to 60% heritability for alcohol and 30 to 50% for other substances. Now, the problem is I can't tell you for sure it's this gene that's causing it, or was this a learned behavior in the family? The other thing is we're not able to account for the environmental triggers like poverty or the social determinants that were previously mentioned. So it's important to look at the protective factors, but the relationships need to be supportive and not enabling. And if you can enhance resilience, that can sometimes mitigate risk early on in the individual. So if the person is taught that they don't have to be a member of the cool kids, they don't have to go along to get along, they can say no, they have a spine where they are taught, I can stand up to say no and just form my own group or something. That takes a lot of effort. That takes a lot of strong parental involvement, a lot of, essentially it's going to take that village to make sure that the environment is not set for a substance use disorder to develop. What environmental factors do you think are most influential based on your clinical settings to set the stage for addiction? Think about the environmental factors. Makil. Oh, he's trying to get admitted. Never mind. Go ahead. Makil, what environmental factors do you see as most conducive to setting the stage for addiction or mitigating addiction? All right, Krishnan.
Parental use of substances.
Oh yeah, that's a big one. Parental use of substance is huge, especially now as we get into THC and edibles, and even something as simple as smoking or the nightly cocktail to unwind. That is all very true. Let me hear from Natalie and then Bellum.
Housing. So like if you're undomiciled, it might be easier for you to like go and like for example, I had a patient in the ED and he has a history of using and he basically wanted to leave because he didn't have enough money to get home where he's from in Connecticut, and he then was like, well, I'm just going to go to the shelter or I could do drugs because the shelter also didn't have a bed. So he was like, where am I going to go? But he, at that time, he may or may not have been sober. I don't really know, but he was getting discharged and he felt compelled. He was like, I'm getting stressed now and etc.
So he was stressed out by being in the hospital away from the substances.
Yeah. Yeah, he was stressed out and he wanted to use.
Yeah. He was stressed out by his lack of access. You're on mute.
Oh, no, nothing.
Okay. Bellum?
I think childhood trauma has a huge role in setting the foundation for later substance use. For example, when we talked about parental use of substance, I mean, I think that says a lot about the environment that this child or this person had when they were a child that probably included some level of trauma.
Bogdan?
I was gonna say, like cultural, environmental. A lot of my patients come from like Latin, South American origins. They migrate up here. They don't really have too much family support. They hang out with the same, you know, cultural similarity individuals, and they drink. And I feel like maybe that is definitely a factor that, you know, they're bored. They don't have family. This is all they do is that they work, then they go out and they drink. They come home, they drink more. They work, they drink. I think that has something to do with it.
You made an interesting point about this lack of purpose. That's a really hard person to treat. Someone with no purpose in life who's basically simply going through the motions and all of their positive feedback comes in the setting of use. That is a very difficult person to treat and help. So the area of brain imaging always rears its head into psychiatry, and it's always very interesting because we're trying to find the magical region that says, aha, and this is your situation. And so functional MRI and PET scans may show altered reward and emotional circuits in people with substance use disorders. Adolescents have a heightened reward sensitivity. So recovery can restore some brain function, but the hope is that someone will say, aha, based on this image, we can offer you something like TMS to that region, and this will cause you to be less prone to addiction or reverse it. I'm very dubious of this because a lot of imaging, all of imaging is essentially correlational findings. And so this gets very hard to determine causation because the problem with imaging findings is there tends to be this emphasis on we're going to find the one cause, as if we're tracking strep or strep as the causative agent for your sore throat infection. And that's not typically how things that we call mental disorders come to be. It's also not as simplistic when it comes to substance use disorders, but I put this here just to raise it and put it on your radar because you will see a lot of this come out. And my recommendation is that you quickly ask the question, is this correlation or causation? And how do we know what came first? All right, so the other thing I want to talk about is lifespan considerations. So substance use disorder, you have to meet this maladaptive pattern with two symptoms occurring in the last 12-month period, right? So you need 2 of the 11 symptoms in 12 months, like increased use or cravings or social problems. And the severity will range from mild to moderate to severe. And what you're going to do for the purpose of documentation is you want to document the specific symptoms that are justifying the severity of the diagnosis. Now, this is all wonderful for charting purposes, but at the end of the day, what we're going to be dealing with is what does the patient perceive about their use? In other words, if they have a persistent desire to cut down, but they're not say, you can see how these get redundant. If they have a persistent desire to cut down, obviously the craving is going to be strong, as will the urge to use. Those two generally come together. So you can see how easy it is to quickly put someone in the substance use disorder bucket. Now, because they have to have it for 12 months, does that mean you're not going to treat somebody who's only had it for 3 months or 6 months? I would say no, you're probably going to treat them and you may have more success because it is not habituated as much. So this is diagnosis for the purpose of getting into certain kinds of treatment, be it rehabs and the like. But suffice it to say, this is the criteria we have to go by. So substance intoxication involves reversible symptoms from recent use, and they have to have withdrawal symptoms when they stop using it in order to call this a substance-induced condition. So if you look at the bottom of the slide here at these substance-induced disorders, one of the things you're going to need to do is distinguish, is this a de novo psychotic episode or is this a substance-induced? And the way you do that is you're basically going to look at proximity of symptoms in relation to consumption. And then you want to know, well, what were you like before you consumed it? And for how long has this gone on? So if the symptoms develop during or within 1 month after significant intoxication or withdrawal, you could call that a substance-induced disorder. So then what you're doing is you allow more time to go by before you apply a sticky label of, say, psychosis or bipolar to see if they can indeed not have these symptoms. Well, what do you think the problem is when you're dealing with somebody who has an addiction? What might be the problem? Well, the problem is you may never be sober long enough in order to see if you actually clear up. People tend to relapse a lot, right? We have people smoking and drinking and drugging daily, every day, so that we never get a sufficiently long enough sober period in order to see if they are truly having a substance-induced condition or a straightforward, primary psychiatric disorder. And so what happens? We just split the difference. And what happens oftentimes is person winds up on the antipsychotic long-term, whether they have it or not, because, well, you've been through the system, you've seen this many providers, therefore you're buying this label, and we feel like we've done something, where we're not actively letting you be drug-free for a period, usually a month, some substances, depending on what they are, in order to see if you are truly having a primary disorder. Velma.
Is it possible, or what do you think about this, if they're just kind of functionally addicted and they're kind of never going to be off that substance, so it's like you might as well treat them like as they are on the substance? Is that a thing?
Yeah, that's going to vary a lot, though, because, we don't know that they're using the same amount consistently. So you're going to wind up overshooting and undershooting, and they're going to present with crisis every so many weeks. And you're not going to know if this is normal reaction to daily life stress, if this is an extra substance, a tainted substance, is this a drug-drug interaction? Yes, at the end of the day, first do no harm. And also you can only treat the willing, right? You will have a 100% success rate if you only treat the ready, willing, and able. If you treat anyone that's not ready, willing, and able to do whatever therapy, there is no treatment and success there. You can't force any of this. You can only help the willing, and you can only help to the degree that they are willing to allow. This now brings me to the point on adolescence. So teens in the developing teen prefrontal cortex, this makes them very prone to impulsivity and vulnerable to not considering consequences of their actions, right? And so the interesting thing about this is the marijuana, I would say, epidemic at this point. So modern marijuana now has about 90% the THC level that we say had in the older days. And so why that matters is it's a very long half-life as well. So what happens is we will often misdiagnose cannabis effects for things like ADHD or psychosis, but they're really doing cannabis nonstop. And so you have a lot of amotivation, anhedonia, withdrawal, inattention, etc. So how might you approach a teenager with suspected cannabis use disorder? What might you do with them? Stop taking cannabis, right? That's very effective. Is it? Just tell them to stop it? No, that's not going to work. What might you do? Because this, I will tell you, is a very common theme in psychiatry. So much so that you will have parents buy their kids cannabis to say, well, it's better than them scoring it from a bad place, so I figured I would buy this for them so we are sure of the source. Go ahead, Natalie, and then Kelly. Natalia, and then go ahead.
I mean, it's hard to say stop cannabis, especially to an adolescent, but possibly like giving a shorter time span to them so that they can see if it affects them.
What do you mean by that?
Like, I mean, not saying abstaining from it completely, but asking them to go like a week or having decreased use for the week. And like maybe like quantifying it so that then you can assess like with them as time goes on.
Kelly?
Maybe getting like a baseline, like talking to their parents or like friends or family or people that know him like before he started acting different and seeing if there's anything that's actually going on. And like I guess this process of elimination.
Mm-hmm. Yeah. So I will say this is very hard to treat, mostly because of how widespread available this is and how we're practically normalizing it. I mean, there's a whole campaign to, quote, destigmatize, decriminalize, make it seem like everybody's doing it and it's natural and it's good for you and that sort of thing. So another thing to look at with respect to adolescence is this critical development window. This prefrontal cortex development continues until about the mid-20s. And what it's affecting essentially is the executive function. And so what you're impairing over time is the very thing that's going to make them successful through perhaps their most vulnerable and yet the most significant time period. Those early 20s, in your 20s is where you're setting up these career decisions to essentially determine the quality of life going forward. Now, it's not to say it can't happen later on, because, full of hope, but it's a lot harder the longer one takes to embark upon developing this prefrontal cortex, enhancing their distress tolerance, and that sort of thing. This is why early intervention with adolescents is so important. Haile.
I was actually I'm really interested to know the answer to that question that you asked, like what is, if telling them stop using marijuana is not the solution, which of course it isn't, like what is? Because I used to work on a child adolescent unit, not anymore, not in years, but on that unit, the clinicians, the only thing they were able to say to try to dissuade adolescents from using marijuana, and I don't know if this is still applicable, but I remember them saying that if you get caught or it's on your record, you'll never get financial aid. You'll never get financial aid or any kind of financial scholarships for higher education. That was the only kind
Correct.
of that was the only thing I remember being used. And again, I don't know if those are the policies anymore. But yeah, I am really curious what your question is, because that never seemed like really sufficient response.
Yevgeny, what do you got?
I think what nobody mentioned and could also potentially answer the question is asking the adolescent directly, why are you using this substance and what does the substance do for you? A lot of times, specifically adolescents, they use something because they see their friends doing it. They're not very educated in the side effects and how bad it is. Also, the fact that it's legal nowadays and you can just walk into a store and buy it. You're seeing adults and maybe certain role models using these substances, so you think it's appropriate for your age. I think that's kind of the biggest factor is early education, and explaining that, these things do have certain side effects. And, if you start using them early on, it's going to slow you down from certain developmental milestones and, certain, skills that you won't be able to gain, moving forward.
That's exactly right. So what you're hitting on is the same reason someone may do marijuana is the same reason they may do any other substance or behavior. You need to get at the fact of what does this allow to happen or what does this prevent from happening? Where are their motivations? What do you want? Some psychotherapeutic interventions, you might ask them to think about how do you want to be thought of, or in 5 years, what would you like someone to say about you? When you're dealing with older people, you might say, if someone were to speak at your funeral, what would you want them to say about you? You can what you're trying to do is figure out what they're motivated by, what they aspire to, what are their values. And then when you're doing something like motivational interviewing, you will see down the road how you can highlight the discrepancy between what they value and aspire to from what they're doing now. But simply saying, stop it, this ain't going to work for you, that's generally not effective. But I will say it's probably helpful to say that too, because nobody ever told me to stop. Nobody said this was bad for me is a really bad thing to have someone say when they turn 30. I thought this was natural. I've been doing this because this was healthy. It was better than fill in the blank. So you can say stop, but that's not the be all and end all. That's not going to be the where this stops, essentially. Erin?
Just to comment on that, I completely agree with what everybody said, and I do think it's very, very, very difficult for adolescents. But finding out the motivation behind it, I think could be tricky, but yeah, extremely important. And sometimes, I mean, I've experienced it myself where you just assume that they know that smoking tobacco, for example, obviously it's everywhere, that it's bad for you. But if sometimes they just need somebody to tell them that.
Yeah, you're exactly right. So you have to realize the healthcare industry is somewhat culpable for a lot of the social ills due to substance that we have. In the 1950s, we told women to smoke when they were pregnant to take the stress off and make smaller babies. That's what we told. You had doctors endorsing different brands of cigarettes, right? And then people would say things like, well, it's good for weight loss, it trims the cravings. And then you had that bit, right? So smoking was encouraged at one time. And then we had the opioid epidemic where we had doctors telling people, no, pain is now the fifth vital sign and breakthrough pain is bad and everyone should be pain-free all the time. That was a problem, right? And then we had also, when Valium came to market, we labeled it euphemistically as mommy's little helper to take the edge off, right? We have communicated to people that all suffering is bad and must be stopped, that there can't possibly be anything good about suffering. Right? Well, the problem is without suffering, there is no growth and development. And so if that can be reformulated, you may find people willing to say, oh, the suffering is not forever, and I can get better at this. The thing is, people tend to assume that life gets easier, and it does not. Life never gets easier. It only gets harder. Well, then how do you do it so well? Well, because you get better at doing hard things. You just keep practicing doing hard things. If you think your life is hard now, wait till you're elderly, as it says on this slide here, right? Imagine with your musculoskeletal injuries and your unsteady gait and your vision that's failing. Did life get easier or did life get harder? It got harder, but you're resilient and you know how to cope. I want to focus now on these atypical presentations of substance use disorder in the elderly. This is a population flying under the radar with respect to substance use disorders. And the reason they fly under the radar is a lot of times symptoms they may develop may be mistaken for normal aging, right? So you may inquire of your elderly person about falls and confusion, memory, and things of the sort. And you'll say, oh, that's just, part of getting older or whatever. Well, polypharmacy and substance use disorder can be a factor. Now, what do I mean? Well, how many of your elderly patients may be on these doses of Klonopin for years? I had this conversation last night about, she was a student in the seminar a year ago, and she said, do you take old people off of their benzos who've been on it for years? That seems kind of mean. And I said, does it seem mean? Or when they get confused and fall and hasten their cognitive decline and we leave well enough alone, who are we helping in that instance? So yeah, I do geriatric benzo detoxes. You have to go slow with those. It's a very careful approach because you have to make sure you're not mismanaging their comorbid medical conditions. And if they've been on it for years, they may have lower distress tolerance and less resilience. And the problem is also there may be some superimposed cognitive impairment, which may make new skill acquisition difficult. So it's a precarious population to manage. And then, of course, if they happen to truly be recovering from, say, a musculoskeletal injury due to a fall, well, now sometimes they're putting the substance on them to treat that acute condition. So it's a precarious population, but you want to survey what your day-to-day is like. Tell me about memory, confusion, falls, and not just assume that it's because they're older. Can you think of any other challenges that you may have seen in the elderly as it relates to substance use disorder? Or is this a population that's flown under the radar for you? Do you ever think of this population as having a substance use disorder? Natalia.
They often don't want to be weaned from the medications. They don't want to stop them. Stop taking them.
Nobody wants to be weaned off these medications. So how might you approach that?
Well, probably the same elements of motivational interview. Ask them to name what happened, what they experienced, what negative consequences they have.
That's a big leap for someone that may never have experienced it. My doctor gave this to me. Go ahead, Abigail.
I think that a lot of times, especially with like the patients that I see, they've been, doing these habits for so long, such as like having like an alcohol addiction, that they don't even know that it's abnormal. And I'll get like elderly patients that come into the hospital and, they'll have had like a fall or something. And then the provider will just order like an ETOH level, come to find out like they actually have, an addiction to alcohol, but they don't know any better because they've been doing it for so long. No one's ever said anything. And now that they finally had an issue because of their age, it's kind of being brought to their attention.
I'll also tell you this. So when I have an elderly married couple and their ritual has been to have a cocktail or two every night before dinner and at bedtime, it gets very difficult to treat this because one may be having an adverse effect, but here you are, you're going to break up this couple's ritual that they may have had for the last 40 years. And so he will continue to serve her cocktails and she may continue to drink it. So that presents another problem, another wrinkle to consider. Elderly people take on average about 5 medications daily, with about 14% of the elderly population on 10 or more medications a day. And these drugs will include things like benzos. And then when they mix in things like alcohol, or their well-intentioned adult children say, why don't you try a little THC? It might take the edge off, right? And those half-lives are very long and their metabolisms are very slow to begin with. You can see how this cascade of events can set the stage for pretty bad outcomes. So that being said, how might you go about starting deprescribing in the elderly, or how might you go about having this conversation in someone who you might need to deprescribe because it's in their best interest? What might you do? How would you raise the subject? Go ahead, Luke. Off mute, Luke.
Thanks.
There you go.
I think it's important to first know just how many medications people are taking and who is giving them, especially in the elderly population, who's giving it, who's administering these medications. Is a family member telling you to take the meds? Are you on your own schedule? I think it's really important to like know exactly what is going in at what time and how they're getting their medication.
That's important to know. Yep. Elena?
Honestly, it's very tough with the elderly. I actually had a patient yesterday talking about it. He's like 80-year-old, and he said, my ex-wife was addicted to oxycodone, but she was functioning and she was fine. He says, I don't see no problem, people taking pain pills, functioning, not bothering anyone. And I'm like, there is a point, but then he's like, so they don't see the problem.
Right.
Especially, this is tough. I don't know how, I couldn't even explain why it would be an issue at this point.
Let me hear from Bogdan, and then Detchen, and then Kirsten.
It is tough. I do agree with that. Maybe bringing in like their social support, family member that maybe like Luke said might be giving them the medication, or someone that is their caregiver, involving them in the conversation and opening up that door.
Detchen?
Hi, how about starting on methadone, like maintenance?
I was asking how you'd even have the conversation. This would be a huge problem to start an elderly person on methadone maintenance. Kirsten.
Okay.
I think it's important just to kind of communicate that you're on their team and wanting what's best for them, and that it's important to look at all their medications, and like maybe we can do better now than we could do 5-10 years ago when we gave benzos for anxiety. We can do better now. Like we have other options. Let's talk about those.
That's all good. Those are very good suggestions, exploring the conversation and seeing where they go. I will tell you the way I do this, because I'll tell you in my practice, I spend more time deprescribing than prescribing. I tend to inherit patients on 10 or more meds with an army of doctors that aren't talking to each other. So I'll just share with you my strategies. First thing I do is I look at all the pill bottles. And then I open the pill bottles to see if what's inside matches what I expect it to look like and see how many are left. I don't count pills, but I'm getting an idea of, are they just got a refill, or are we needing a refill sometime soon? The other thing I will do is I write down all the pharmacies that they have used. The pill bottle is helpful for that. And then the other thing is I will write down the doctor's names that have been prescribing these drugs. And then the first thing I do is, before calling the doctors, is I will call the pharmacy just to make sure I have all the list complete. I say, hi, I'm Dr. Zakhari. I'm seeing so-and-so. I'm trying to do a medication reconciliation. Can you tell me all the prescriptions that have been dispensed to her in the last year? And when did she pick up the last refills? Oh, and also tell me, who are all the different doctors prescribing to her? So that's how I get my medication reconciliation using community resource. The other thing you can do is certain electronic prescribers will let you pull a patient history and you can see what all the different medications are. And if a lot of states now have something on the equivalent of the iStop program. So then you can log in there and see. And interestingly enough, iStop does register marijuana dispensary as well. So when you look in iStop, you can also see if they're getting marijuana. And so that's one way to start with the medication reconciliation, to kind of harmonize. And you are exactly right in pulling in whoever else is the care partner, be it an adult child or a family member, maybe a court-appointed guardian, but you want to pull that person in as well, because what you want to do is figure out who might be working against you. In other words, the guardian may like them sufficiently medicated and doesn't want to rock the boat, Or the guardian may say, no, I really want to work with you, but she won't listen to me and I don't know how to get her off this. So then the other thing you want to do is figure out what symptoms and conditions might be exacerbated by the meds they're on. And maybe you start deprescribing by the meds they're not so attached to. So my 80-year-olds are not very attached to their cholesterol medicine. They're also not very attached to maybe like a lot of their supplements. And so they see that as a way to wind down. The reason that's helpful is then you say, well, look, this fall you've had or the memory impairment that you're suffering with can be made worse with this dose of fill in the controlled substance name. And that's true because basically they're all central nervous system depressants, right? They are going to make your balance worse. They're going to kill your motivation and they're going to impair your memory and they'll cause constipation. Believe it or not, it's the constipation that gives me the biggest bang for the buck when I say, if we just reduce this a little bit, you may find that your constipation is better. Well, that tends to be the opening that I need. And so you go very slow. Now, the other thing you have to keep in mind is they're taking this medicine for a legitimate purpose. So you better have a backup plan when you take that away. So sometimes I will use something like a really low dose gabapentin and say, when you have this exacerbation, this pain, this anxiety, take 100 milligrams of gabapentin with a full glass of water. And so you can gradually maybe start to go up on that, but every time you add a gabapentin dose, you have room to come down on something else. So they don't feel like they're being left without. The reason I like gabapentin is because the increments of dosage are so low and the therapeutic range is so wide, and you can take it more frequently. So if their maladaptive method of coping is to take GABA, then they can take it without causing secondary insult to themselves. The other unique thing about gabapentin is the higher the dose you take, the less your body actually absorbs. So it actually works better in smaller increments. People that have had me for 719 can explain that to you. If you're more interested in that, you can look into the varying order of pharmacokinetics to explain that more. But suffice it to say, it's a conversation to lean into what is it you would like your life to be like? What symptoms do you want to reduce? How might it get better in trying this? Again, you can only do to the degree that you want. The other thing I will say is, when I'm in the process of deprescribing, I let them know that they need to turn all care over to me for this process. And then I call up all the other doctors and say, hey, so-and-so is seeing me for this purpose. I'm going to help get them off. I need you to not prescribe anything to them until, say, 30 days or till I call you back or something. And a lot of those doctors are willing to work with you because they've been wanting to do this for years, but they've not been able to do it in their 10-minute visit that they're having. So when they see me for an extended visit time, we have time to have a longer conversation and pull in the other interested and stakeholder parties. And so what you'll find is they'll go along with it because they know they can reach somebody. When they panic, you'll help with their symptoms, and you've blocked access to the other docs. Now, some are very smart, and some will just basically say, look, I have my own stash. I'm only doing this because someone is forcing me. And at that point, you have someone that is not willing to engage. You can't force the issue. So I hope that was helpful to you. Now, let's talk about life stressors across the adult lifespan. So these are popular age ranges in which you may notice use begin or uptick in relation to these developmental or major life stages that they may encounter. So for example, young adults may face a hard time forming an identity. Middle-aged adults may be juggling career and family. Older adults are struggling with loss of career, retirement, or family members. And so these things can be impetus for starting a substance or accelerating the use of a substance. 2008, when the housing market went down, I had a pop in my addiction patients in 2009 and 2010, and they will tell me, I didn't drink until 2008. And what do? I work in banking, I work in investment banking, I'm a corporate lawyer, et cetera, et cetera, et cetera. My whole company went under, I got merged, I got downsized. My portfolio took a major hit. That's when they started drinking. Another major one is also you will notice, so major world events like that, sometimes people will start drinking if they've had the loss of a loved one, suddenly they got laid off, forced into early retirement. So that's something to keep in mind as what may have been the precipitant or the perpetuating factor even that's keeping this thing going. Substance use disorders can affect jobs, relationships, finances differently at different stages. So if you're young and hip and everyone's drugging, you may not have perceived that it's hurting your relationships. But if you find that your spouse is going to leave you, or you've suddenly been fired, or you're on a performance improvement plan due to the substance or the gambling or the whatever, that may be the disruptor that says, okay, I really have a problem. Some people will not acknowledge a problem until it comes to that. In your experience, what life stage have you seen most of your substance use disorder patients? Lifelong users or newly developed users, or where have you noticed patients with substance, or have you even thought about it in terms of life stage when you see them? You may not have. Yeah, Bug.
I only work with the adult population in my facility, and so I've seen it mostly in middle age, between the 26 to 59, depending on, like you said, financial stressors or things that they're going through on a day-to-day basis, some sort of stressor that caused them to, um, revert back to substance abuse.
Mm-hmm. Thelma?
I work in inpatient hospital. I go to all the units, and the time I see patients come in with drug or alcohol, they're admitted. It's because they've basically hit rock bottom. Like the ones that use alcohol fell and had a really bad injury, or they got so sick they couldn't survive outside.
Mm-hmm, mm-hmm. So now I want to talk to you about this issue also about dual diagnosis. I want to talk to you about gender and cultural considerations. So people tend to overlook this as well, but there are some gender differences in how substance use disorders may progress. So women tend to show this telescoping effect due to higher vulnerability to stigma, different triggers, and various treatment needs. So, and by the way, telescoping simply just refers to a compressed timeline from when they used it to when it became a full-blown addiction. That tends to happen faster in women. So think of it like a telescope collapsing on itself. That typical progression just gets condensed into a shorter time frame. Women typically will develop addiction within 3 to 5 years sooner than their male counterparts after first use. And the transition from experimental use to regular use to dependence to severe consequences is just accelerated. But also earlier and more severe consequences can happen in women as well because of the progression. So the neurobiology is the same in both, that it enhances dopamine, essentially this dopamine feedback mechanism. But in women, estrogen enhances dopamine response. The other thing that's unique to women is that they have lower water content, higher fat percentage, and that can affect drug metabolism. Also, enzyme differences such as variations in alcohol dehydrogenase and other metabolic enzymes. So it degrades slower, sticks around longer. And so those are some factors to think about. Now, the other thing to realize is men, for example, may drink heavily for 10 years before they develop any liver damage, whereas women will show damage in as little as 5 to 7 years. Also, women tend to develop cardiac complications and psychiatric symptoms faster when they use stimulants. Opioids, they tend to escalate the dose more rapidly. And so as a result of the high dose, they're more prone to overdose. Liver, heart, and brain effects tend to appear sooner in women, as do fertility and pregnancy complications. They tend to emerge more quickly. And then women also tend to develop the nutritional deficits much faster, developing the malnutrition downstream effects. Now, why women don't seek care as readily? Well, a big problem is 70% of women in treatment have children under the age of 18. And so they're also often economically dependent on partners who use substances. So it's the only way to keep the peace is they use along with the partner. The other problem is they're often very fearful of child custody situations, so they may not be inclined to come to care. I will tell you, a lot of times when I have a woman that sees me for detox, the request will come in on a Thursday and it'll say something like, I need to get sober for a custody hearing on Monday. And it's now like Thursday evening. What can we do? And I need to show that I'm in treatment. So a lot of times custody is a major factor. Now, unfortunately, loss of custody is not always sufficiently motivating to stop the addiction, which gives you an idea of how difficult this can be to treat. Now, there are major social barriers that women especially have to contend with. Addiction may be likened to failing to fulfill their societal role of maternal caretaking, so there's that stigma that gets put upon them. Also, they tend to lose a social support network. Women tend to be more harshly judged if they're using, if they happen to have children, by their peers. And also women in substance use and with addiction tend to have higher rates of intimate partner violence. Also, women tend to have a higher incidence of sexual and physical trauma on the order of about 85% compared to 35% of men. And then, of course, if they're in religious circles, addiction may be viewed as a moral failing. Shame is always a factor, regardless if they're men or women. It just prevents disclosure. They may not want to tell you what they're doing for fear of shunning, essentially. So you can see that there are a lot of different dynamics at play. And so women may grossly underreport. And, you know, most clinicians are biased and don't expect women to have these kinds of problems, so they may not even ask. And so you may have a don't ask, don't tell approach that tends to occur. So there are some co-occurring psychiatric diagnoses. We call this dual diagnosis. This was a very popular treatment trend in the late 90s, early 2000s. People were opening dual diagnosis units. Now I just assume this is par for the course. What are you going to do? Not treat the mental illness alongside the substance? There are some places that say, nope, can't treat you till you're off the substance. Go get off the substance first. And, you know, basically what that clinician is doing is cherry picking the most prime patients for successful outcomes. But 50 to 75% of substance use disorder patients have a mental disorder like depression or PTSD or anxiety. And generally, what you want to do is screen and universally treat both of the conditions concurrently, because they may be treating their underlying psychiatric disorder with the substance. I'm just doing the best I can here. I'm anxious, I'm stressed, marijuana helps, opioids help, alcohol helps. That's all I'm doing. So that's all we're doing here. So help me out. And so that's why it's important to take this both and approach. Don't treat the people in a silo, essentially. It's not helping anybody. Kelly, you had a question.
Not a question. I just wanted to
Comment?
state something.
Yeah.
I have a family member that at a very young age she started drinking because she was bulimic and anorexic, and in order to forget about her like the whole eating aspect, she started taking up drinking, and then she ended up using drinking to deal with her sexuality because she believed she was gay and she liked girls, and then her mother was against it, so she would date guys and get really drunk, and it became this whole cycle, and that's how everything and she's still dealing with it. It's 20 years now, and she's like now married to a guy, and she just recently found out she's gay again, and she's cheating on the husband, and she's drinking, and she has 2 kids, and it's just spiraling. So it's just this issue that never.
Yeah. It's very complicated. It's a very complicated condition to treat. And now, as a result, you can see it's having a ripple effect beyond just her.
Mm-hmm.
You know,
it's affecting the whole family.
Right, right. Substance-induced psychiatric symptoms emerge during use and withdrawal, but then typically will resolve within weeks. Some things to pay attention to may point you to the substance that is causing it. So ideally, you wait about 2 to 4 weeks post-abstinence to reassess for a primary psychiatric disorder. So the way you would distinguish a substance-induced from a primary psychosis. So the main thing is onset and timing of symptoms that emerge during intoxication or within 1 month of substance use. And symptoms will typically resolve in 2 to 4 weeks of abstinence. And severity of the symptoms will often correlate with the amount and frequency of the substance being used. And certain substances have predictable psychotic profiles. So there's like, if you're taking my patho class, we talked about fever patterns, but here we have hallucination patterns. So visual predominant hallucinations, these are more prominent, are more common than in primary psychotic disorders. So primary psychotic disorders, less common to have visual hallucinations. Tactile hallucinations, I feel the creepy crawlies, pins and needles, that's especially common in things like stimulants, cocaine bugs, or meth mites, you might hear them called. The other thing is formed versus unformed. It's often, if it's substance-induced, the psychotic, the delusion is a little primitive. It's not quite formed. Than schizophrenia, where they were in a prodrome for a long period of time, and then the psychosis and the delusion that goes with it is very well formed, and there's a whole world that goes with it. When it's substance-induced, it's not quite a complete delusion. The other thing to keep in mind is if it is substance-induced, they often will retain some sense of awareness that the experience is not real. Whereas in psychosis, primarily, they believe everything is real. And this is really, the world of their own making, the break from reality, which is what psychosis is. But if they're having psychotic symptoms, but they're retaining some awareness, that could be a tell that this might be a substance-induced situation. Primary psychotic disorders, on the other hand, will predate substance use depending on the age of onset. Symptoms will have existed before they started consuming, and then it persists during abstinence. So 4 weeks after use, they're still having it. The other thing is primary psychotic disorder is very gradual in onset with a progressive functional decline over months to years. Substance, it's kind of quick. And it may, substance relationship may worsen with use, but it doesn't originate from the substance. So you may be truly schizophrenic and someone convince you to smoke marijuana to help you, and then you get more psychotic on the marijuana. So it can make worse the baseline symptoms. The other thing is the primary hallucination in someone with a psychotic disorder is auditory. And the primary psychotic disorder typically comes with what we call the 4 A's. You've heard the 4 A's of psychosis. Well, we'll talk about it in the psychosis lecture, but for your purposes here, avolition, alogia, anhedonia, and affective flattening. So alogia, they're not speaking, they're internally preoccupied, what you call negative symptoms. Primary psychotic disorder will have a formal thought disorder. They may have loosening of associations, cognitive impairment, executive dysfunction, all separate from substance. Stimulants, on the other hand, like cocaine, methamphetamine, amphetamine, they will typically have like paranoid, often persecutory delusions. They'll typically be a theme of law enforcement. Their visual hallucinations will generally consist of shadows or movement in the periphery. If they're elderly, by the way, and this happens, you have to also be careful because they may be having a different kind of visual hallucination due to glaucoma or cataract or visual impairment. So that we'll talk about when we get to underlying medical conditions that can mask psychiatric symptoms. People with stimulant use disorder may report bugs crawling sensation, visual hallucinations like shadows. Hypervigilance, you'll notice in people with stimulant use disorder, so a lot of scanning behavior and checking locks and checking windows and check your six and that sort of thing. And then it resolves usually in about 2 weeks. Stimulant symptoms resolve pretty quick because if you think about the half-life of the medication, it's pretty fast. So the half-life from Psychopharm will tell you about 5 to 6 half-lives before it's completely out of your system, 5 to 6 half-lives before you check a therapeutic level. Cannabis, now this can cause the paranoid ideations, and they will have things like suspiciousness and referential thinking. They'll think everything means something. They also will have feelings of depersonalization, derealization. That's to say they're detached from the environment. They may be floating above. They may have a distortion of time, so an altered perception of time going by. Wow, I feel like 5 hours have gone by. It's been 5 minutes. Anxiety driven, so they're often anxiety provoking rather than an organized delusion. So they're not going along with the delusion, they're stressed out by it. And then with cannabis, it's very dose dependent. The higher the potency, the more likely that will be the case. Alcohol, this is where we see the delirium tremens. So these are the people in withdrawal that will have hallucinations, often insects or small things floating in front of them, creepy crawlies on the skin. It usually will resolve in about 96 hours. If it resolves in 96 hours, that's typically the alcohol's left the system, and the cerebral and the central nervous system is no longer misfiring. You will see that resolve. If it persists beyond, probably not alcohol. The emergency you need to pay attention to in anyone's condition is autonomic instability. The blood pressure, the heart rate, the profuse sweating, and thermoregulation is disordered. And this especially becomes true when we talk about things like hallucinogens. So hallucinogens include things like LSD, psilocybin, PCP. Those hallucinations are primarily visual, but they're geometric patterns, color distortions, and morphing objects. That's the visual hallucination that someone on a hallucinogen might have. They also will have something called synesthesia. Synesthesia is this cross-modal sensory experience. I can hear the color blue or red, something like that. And also their insight may vary. So they might know that they're indeed tripping or believe the experience they're having is real. And this is something to keep in mind. There's a condition or a scenario called hallucinogen persisting perception disorder. Hallucinogen persisting perception disorder, HPPD. And this happens with things like the synthetic drugs, K2, spice, and bath salts. It's unpredictable in the presentation. They typically will have severe agitation, often with violent, bizarre behaviors. And they'll have a lot of mixed symptoms, combination of stimulant and hallucinogenic types of symptoms. And the course can be prolonged. It can take weeks to months to fully resolve this. So obviously, when someone's in this situation, you're talking about maintaining clinical safety, preventing self-harm, preventing harm to others. And the problem we run into is we say you want to avoid antipsychotics because they can worsen the situation. And we typically will use benzos for sedation. But sometimes antipsychotics will have to be used, and you'll have to essentially gamble, especially if you're dealing with PCP. Now, here's the thing to keep in mind. These are the ones we can test for, but if any of those chemical structures change, we may never be able to test for them, because unless you know what you're testing for, you can't test for it. So that's why having these clinical descriptors may give you an insight as to what they're on. But at the end of the day, the treatment is all going to be symptomatic support, prevent the harm to themselves and others, allow sufficient time for the drugs to pass so that you can make a proper diagnosis and not mislabel somebody. So let's take a look at this case here. Take a look at this case study here on the screen. You have a 45-year-old female with opioid use disorder, moderate and chronic pain. The patient initially was prescribed oxycodone following a back injury, say 5 years ago, and has been escalating the dose and obtaining pills from multiple providers. She reports withdrawal symptoms when attempting to reduce use. And recently she's divorced with custody issues. She has a son who's 17 expressing concern about medication use. Take a look at this case study and think about what's one intervention you would prioritize. And let's schedule a 15-minute break right now while you think about this. And then I will come back and reunite with you at 8 o'clock. So let's think about this. If you think of it, you can put your answers in the chat and I'll take your questions when you return. Okay, so in this case study, we have this 45-year-old patient who's got opioid use disorder, who's escalating due to chronic pain, and she faces withdrawal. She's not in withdrawal right now. She faces withdrawal because she needs more. That's not withdrawal. And she has a lot of social stressors like this divorce. And it looks like she's scoring appropriately moderate depression on the PHQ-9. She's got a history of chronic pain. She's got some lifespan considerations that she's in middle adulthood with competing caregiving responsibilities. There's an impact on the adolescent son at a critical development stage. And there's some chronic pain treatment that's needed. And she's maybe in menopause. So my question to you is, what was one intervention you to prioritize for this patient? What would you do for this person? So this person is seeing you probably, let's say, for the first time, likely in an outpatient setting. There is no sign of acute withdrawal here, so take withdrawal off the table. And these are her complaints. What do you want to focus on here? Well, I'll tell you. She is worried, first and foremost, about this advanced pain, right? Go ahead, Bogdan. What do you got?
I was going to say you want to build that therapeutic alliance with her and then maybe do that motivational interviewing with her to
Turn on
try
that motivational trick. I got you. To what end, though? To what end?
I think the depression and anxiety are the biggest factors here. I mean, that's what's perpetuating everything else, in my opinion.
Possibly, but in her mind, it's pain, and she has a chronic pain condition. Balam?
Yeah, I think I would build an alliance with her and just say, I want to address your pain first. And I think my first proposition might be, can we add in a second agent like Cymbalta or something that might help with the chronic pain with the goal of maybe titrating down the opioid use?
Yes, that's a very good plan, because what you're doing is you're kind of doing this 2-for-1, where you're helping with the pain, but you're also maybe addressing some anxiety and depression symptoms at the same time. That's a good plan also. The other thing would be, you want to take a look at her medication list and see what all she's on, because some of the problems you'll run into, though, is when you start prescribing things that have an SSRI component in somebody that's on opioids, is you may induce a serotonin syndrome. So you need to be careful not to make the situation worse. The other side of it is she might just need better pain management. That is to say, pain management is more than just opioids. There might be some adjunctive things to work into. So is she willing to engage in, say, TENS and topicals and nerve blocks and physical therapy and contrast therapy, heat and cold, that kind of thing? It might be very helpful to find out if she is actually having pain or if you can distinguish between anticipatory pain. The other thing I would always ask about is sleep, because if people are not sleeping well, then they have less physical and psychological resilience and everything is heightened. But that's a very good point as well. So you're right to build the therapeutic alliance, but if her main concern is pain, you need to find a way to come alongside and do that, or she will continue this doctor shopping that it says she's doing here as well. So the clinical assessment needs to prioritize them in a biopsychosocial format using age-appropriate tools, and you need to be very vigilant towards polypharmacy and also cultural factors, because you may have the best intentions, but if someone believes that what you're doing is essentially witchcraft, they're not going to be interested. I had a consult recently for someone that says they're a Christian Scientist and wants nothing to do with traditional medicine. However, there's a lot of problems that are developing. And so you kind of have to do this coming alongside. And if her faith is in prayer, you can pray at the same time. And if you find that helpful, and you maybe prescribe the prayer, say, well, can you do it 4 times a day? Or can you, you find a way to lean into what it is they're willing to do. What you're doing is restoring agency and trying to get them to be less of a victim of their circumstances so that they can feel some degree of power. Okay. Take a look at this case here. There's a 32-year-old man with alcohol use, mild, with a neurocognitive disorder. The patient reports increasing memory problems after 10 years of heavy drinking, about 1.5 liters of vodka daily. Recently fired from a job due to errors and missed days, lives alone with minimal support. Mental status shows poor attention and concentration, impaired short-term memory, mild confabulation when questions about recent events, and minimal insight to alcohol's role in the cognitive changes. So the key biological factors are nutritional status, liver function, neuro exam. Psychological factors include depression screening, cognitive assessment, and social support, housing, and housing stability. He's 32 years old, so this young adult, potential for both recovery and worsening of cognitive status because of how long he's been using the alcohol. But, the younger brain has got a better hope for recovery. How would you approach this person? What might you do here? What's he coming for? Start with what they're coming to you for. That's where the alliance will be. If you totally disregard their complaint, then you will not build the alliance. So if they're coming to you for what? Neurocognitive impairment, then maybe that's where you start. Okay, we'll just put it on a test. Moving on. So let's talk about substance categories and clinical features. So alcohol use disorder, the big thing here is the issue of impaired memory, ataxia, mood lability, and withdrawal ranging from tremors to delirium tremens. So the big things you don't want to miss here is if the person is intoxicated versus in withdrawal. Because if they're in withdrawal, this constitutes an emergency. Because these drugs, alcohol specifically and benzos, are central nervous system depressants. And if they're rapidly whipped away, then you have a rapidly awakening central nervous system, which can misfire. And that's the thing that predisposes you to things like arrhythmias and seizure disorder, which then can eventually compromise airway. So I'm going to give you some big red flags that you don't want to miss in someone with alcohol use disorder, and you don't want to miss the withdrawal. One of the major red flags is hyperthermia, a fever greater than 101. The other thing is to pay attention for seizure-like activity and altered mental status, confusion, disorientation, something beyond simple anxiety. If they are extreme blood pressure fluctuations, that's another thing to pay attention to. Drenching sweat despite normal temperature, diaphoresis, hallucinations, seeing bugs, animals, or creepy crawlies of any kind. And then one of the biggest tells is if they have a history of DTs, that's a good predictor of future DTs. So that's something to consider when someone tells you about their wanting to stop drinking. Major medical comorbidities can include heart disease, liver failure, and various infections, especially pneumonia, urinary tract infections in the elderly. And you want to look for concomitant use of benzos and barbiturates. They typically may have severe malnutrition, and you're most worried about thiamine deficiency. So these are the red flags that you need to capture. Otherwise, something far worse will happen. So the way you'll do this is you can certainly use the CWA scale, that clinical indicators of alcohol withdrawal. And depending on the score, that will classify mild, moderate, or severe. If they're over 15, just so you know, that's typically an ICU situation. So you want to obviously prevent that. The best way to do this withdrawal management, we don't like to say detox as much because you're not really giving them anything to detox them. All you're doing is you are supporting them in their withdrawal. And that's kind of why we use long-acting benzos. And so long-acting benzos would include things like Librium or Valium, or maybe phenobarb. If they're elderly, sometimes lorazepam is sufficiently long-acting. And you can go one of two ways. You can either wait for symptoms to develop and give it to them, or you can preempt it. So when I'm doing this in the home, I preempt it. I basically load them with Valium. I try to get them about 100 milligrams of Valium in the first 24 hours. And that half-life is very long. So if they decide to kick out the nurse on day 2 or 3, I know that they're not going to go into acute withdrawal. And then I supplement them with things like gabapentin. You'll always want to contend with the thiamine. You can look up why thiamine needs to be given before any glucose administration. And obviously folic acid supplementation, magnesium, and fluid support as well. So if they can drink by mouth, they're not vomiting, the airway's intact, you can do this at home with support. If they can't drink by mouth, I don't recommend we do IV things at home, just because that's a whole nother level of care. Now, I know there are all kinds of IV spas and things that will do this. They don't bear the same liability that you will bear. You should also know to look for Wernicke's versus Korsakoff. So Wernicke's is the acute manifestation. There's a triad that you would assess: ataxia and nystagmus and confusion. So ataxia is the gait, confusion, and the fluttering eye. Only about 10% have all three. But if they have all three, it would be really bad if you miss this. So that's kind of a big deal. This person's going to get 500 milligrams of thiamine IV 3 times a day for 3 days and then 100 thereafter. So if you're shooting IV, this is probably your hospital patient because this is pretty severe. Korsakoff is the chronic version of this. It's gone on a long time. They may have antegrade amnesia. They can't form new memories. They may confabulate. Unfortunately, Korsakoff's is often irreversible, even with thiamine replacement. Alcohol does make it worse. They're at much higher risk for oversedation. So that is something to definitely keep in mind. And then, of course, if it's really severe, you may notice the bleeding abnormalities and the changes in the CBC with the platelets and the MCV. And so you also will notice the elevated liver enzymes. So all of that will give you an indication as to the severity of the condition you're contending with. With opioid use disorder, the other thing we have to worry about, are they acutely intoxicated? Are they in withdrawal? Now, someone asked the question, why is benzo withdrawal worse than opioid withdrawal? So benzo withdrawal can actually lead to death. The arrhythmia and the seizure can lead to death. Opioid withdrawal does not lead to death. It's very uncomfortable. People have described this as severe flu-like symptoms. You want to wait for the patient to be at a sufficient degree of withdrawal as measured by the COWS scale before you give them something like Suboxone. And the reason you want to do that is because Suboxone, if they're not in sufficient withdrawal, will give them a precipitated withdrawal because it will accelerate the opioid off the receptor, and then you'll be really stuck and you have nothing more to give them but more Suboxone. So I tell you, give all the supportive meds, gabapentin, clonidine, stop the opioids all at once. When that COWS scale gets to 10, give them that first dose of buprenorphine or Suboxone. If you're dealing with a pregnant person, it's buprenorphine because the naloxone is not approved in pregnancy. But suffice it to say, I typically only use Suboxone in the non-pregnant and everybody else. So I only use Suboxone. And the reason is it helps prevent diversion as well because it's mixed with naloxone. So that's something to keep in mind. but you're basically waiting for them to be in the scale. So this clinical opioid withdrawal scale is free online. You can look it up in MedCalc. I have a video online too reviewing it for home detox. But familiarize yourself with the CEWA and the COW scale. Just be very familiar with it. Okay. Now, stimulant use disorder, the big ones we focus on are cocaine and amphetamines. And the mental status exam will generally match someone that's jacked up on cocaine or amphetamine. So obviously pressured speech and hypervigilance, grandiosity, and the accelerated vital signs. Now, there are other stimulants that we like to talk about, like say nicotine and caffeine. Caffeine's from the baby Jesus, so I'm not going to get involved with that one here. But suffice it to say, you can certainly obviously become addicted to caffeine. Now, I don't know anyone committing crimes for their Starbucks. They may think about committing crimes for the Starbucks. They may say, I'm going to kill someone if I don't get my coffee. That's possible, but they don't act on it. And so that's why I think we don't typically jump all over caffeine unless it's causing problems. Look, if you're having PVCs and PACs and arrhythmias and you're still drinking the caffeine despite, then we need to have an intervention. But most people are not disturbing social fabric over a cup of coffee. But you can see what the various caffeine concentrations are there. And the withdrawal typically will be, you know, think about when you don't get your coffee, headache, fatigue, difficulty concentrating, irritability. This all goes away fully in about 2 weeks. And you can do NSAIDs or Tylenol for the headache symptoms they're having, but this basically goes away. The problem is life is so much better on cocaine for people that use it regularly, that regular life becomes boring, and that mundaneness tends to be very difficult to overcome. So when someone's acutely intoxicated on cocaine, generally happens within minutes of them ingesting it. The big risk, of course, is you can cause a vasospastic MI, aortic dissection, even in young patients. And it's often, their paranoid delusions are often persecutory in nature. And so you just kind of have to be very careful about that when they have it. The other reason it's important to know, and I recommend a tox screen in any young person presenting with a heart attack, is this issue of giving them beta blockers. That can cause a major complication. So if a young person is having an MI or symptoms of an MI, while you're working them up, they should have a tox screen. And obviously that's intended for an acute care situation. Cannabis use disorder. So I put this up here just to give you an idea of what the dosage in cannabis looks like then versus now, and how kids and people are trying to really increase the THC, which is the psychoactive component of this. Impaired memory, amotivation, paranoia, those are the symptoms we're going to see. The other thing to look at is vaping-related lung injuries. This is becoming a growing issue. You'll notice when the COVID pandemic hit, the big story in the news before COVID hit was all of these vaping-related lung injuries. You can just do a Google search of what was hot in the news at the end of 2019 and the beginning of 2020. But interestingly enough, the damage is pretty severe. It's like an acute inflammation. So that essentially, that virus added insult to injury. Cannabis has undergone a dramatic transformation from the usual 3 to 5% THC marijuana of the 1960s to 80s. Today, everyone's using ultra high potency products, and this is fundamentally a different drug, especially in adolescents whose brains are still developing. And you can take a look there on the right side of the screen as to the different concentrations and the different formulations. But this is a very important distinction. It's a 3 to 5 time increase risk, especially if they're doing it daily. And a lot of them are doing this daily, this high potency cannabis and THC. And the problem is vaping is hard to detect. So you can have an adolescent essentially vaping THC all day, and the higher the dose and the frequency of the dose is directly related to the intensity of the psychosis symptoms. Now, does it cause it? No, per se, but some people would say it may unearth what was predisposed and make it show up sooner. So you will notice the very similar symptoms to psychosis: social withdrawal, odd beliefs, perceptual changes, paranoid delusions, hallucinations, etc. So it's something to pay attention to. The most important message I want you to get out of this slide here is that for teens, this high potency cannabis poses the most significant risk to their developing brain. And vaping related lung injuries can happen very quickly and severely. And so this is not about moral judgment, but this is very much a physical protection, a bodily protection. This is an urgent matter. So it's not just pot. Let's not minimize it. No, kids won't be kids. They're experimenting. This is really a big deal, but it's going to take some hard work to undo it. Nicotine, what can I say? People are still addicted and love it. It goes in style and out of style. Some people were saying smoking is down because marijuana is up. And then people said, oh, marijuana is getting a bum rap and now smoking is going up. So is there something to be said for the old Freudian oral fixation that might be related to this? I don't know, but suffice it to say, there are medications approved to help people quit smoking, but there's a lot of social cues and environmental cues that go along with it. So it's never strictly just about the cigarettes. It's about what it brings and how they see themselves when they're smoking. Oh, it feels so good. I look so great. I have that first cup of coffee. I'm in social settings and all of that, right? So it's not just about the cigarette, but the cigarette will keep it reinforced. So let me see here. So under, this is obviously under-addressed. And why do you think it's under-addressed? Well, I'll tell you why it's under-addressed. Because if I'm dealing with someone that's got bigger fish to fry, and this is not their primary issue, you know, someone that I'm trying to get to take their antipsychotics or to keep off of using other medications, you can see how this gets downplayed. But this is often a gateway drug. They start with this, they start smoking, especially in the teen years, and then we go to marijuana, and then we go to vaping, and then it's not enough, and let me try this and that. And so this can definitely set the stage for further consequences. This is popularly addressed in primary care. I don't typically see a psych referral for nicotine use disorder. The hallucinogens. I want to spend some time on the hallucinogens. So managing hallucinogen-related symptoms is difficult because, one, hard to test for. Two, the duration of symptoms is hard to manage also. You can have it for a very long time. They're not the most reliable people to keep coming back to care. And we're not going to admit them for 30 days to make them overcome this hallucinogenic effect. So this is where you really have to rally social supports around them. So that's part of what makes this very difficult to treat. There's no pill for this. And if you're doing psychotherapy on someone that's actively intoxicated on a hallucinogen, I'm not sure how much is sticking and how much is essentially just, you know, wasting time essentially, because nothing is sticking per se. So this is what makes this very difficult to treat. We require a high degree of willingness and readiness. And ideally, the person would come in and say, I use hallucinogens, it's a problem. I'm here now when I'm not intoxicated to get help. That's the right patient you're going to be able to treat. But other than that, it's going to be acute care management and keep them safe. Sedative hypnotics. If you've not seen the documentary about Xanax, I highly recommend you look into it. This is perhaps a much larger epidemic than opioids ever was. This is so prescribed and maintained by the current healthcare community. These are highly addictive. There is no reason for anybody to be on years-long benzodiazepines unless you have a very specific seizure disorder and you're managed by neurology. No psychiatrist or psychiatric prescriber should be prescribing benzos longer than 2 weeks. I will tell you right now, I've been practicing 17 years, and in this private practice, I can count maybe on 2 hands the number of benzo prescriptions I've done, and the majority of them were for hospice patients. Hospice. The remainder were, I need one to get on the plane. I need one to go in the MRI machine. I never prescribe benzos for any sort of long-term use. Also for detox. I use it for alcohol detox. Very controlled, measured, no more than 5 days. I usually have a nurse with them. I use Valium because it's not enjoyable. So please, and where you're getting this is in primary care. I have 15 minutes, you have anxiety, here's your Xanax, out the door. That's what's happening. The problem is they wind up on this for very long term. It can be very hard to come off of. And it's not just benzos, it's the Z drugs, Zolpidem, and any of the drugs with a Z, Ambien, Lunesta, pick your favorites. These are all very hard to come off of. And obviously the cause is sedation, ataxia, cognitive impairment, high risk for fall. Oh, and by the way, why do they get stuck on them? The patient doesn't want to come off, and the prescriber is afraid to suddenly stop it because the withdrawal could be fatal. Velma.
Sorry, can you speak to why the specific reason why benzos should not be taken long term?
Yeah, because they're highly addictive, and they also can cause these. What happens is you will need more and more to achieve less and less, and they're highly addictive and sedating. And so the problem now becomes you also will get downstream effects like cognitive impairment, difficulty with balancing. You're taking them and driving, operating heavy machinery. Essentially, you're sedated. Think of a benzo essentially like a pill form of alcohol. Do you want a cocktail before you get in the car? Do you want a cocktail before you go do surgery on somebody? Do you want a you see what I'm saying? It's like alcohol, but in a pill. And it's hard to come off of because when you stop it, the withdrawal can be fatal.
Okay. And do they also have like long-term effects on like the GABA system?
It can. Not everybody has withdrawal. That's the other problem I should clarify here. A lot of people have withdrawal. Not everybody has withdrawal. The problem is I don't know who's going to have withdrawal, and the withdrawal can be fatal. So as a result, I just assume and treat everybody as if they could have withdrawal when I'm seeing them, because if not, the outcome can be severe. Go ahead, Bella.
I'm sorry. Could you just I know this is not a one solution for everyone, but an example of how you might titrate someone off of a long-term benzo use?
Depends on what you have and what they're willing to do. So my population's probably not the norm, but when I see people for addiction and detox, they want to get off quickly and move along. So I typically will load them with 100 of Valium in the first 24 hours over divided doses. So something like 20 milligrams every 5 hours, every 4 hours of Valium in the first 24 hours. I make them do this with a nurse with them present, and then I supplement with gabapentin as needed. And I'm really focused on making sure we consolidate the sleep. That Valium is going to take about 100 hours to leave their system, and it's long acting. And so the reason I do that is that reduces my risk of acute withdrawal, which reduces my risk of having these seizures and arrhythmias that they may develop. Now, if you're doing this in the community setting and you have good buy-in, again, you can switch them to Librium or Valium and see if they're gradually willing to come down. Most of them are on Klonopin already, and that's hard to come off of. And you will see all kinds of methods on the internet. There's various opioid withdrawals. In fact, the APA, I believe, put out a guideline now as to how to get people off of long-term benzodiazepines. So you can check with their guide as well. I've just been doing this long enough where if it's in a controlled setting, you can come off. The biggest problem I have is as soon as they come off, they're fine for a few months, and then they doctor shop and find someone to put them back on. So that becomes the problem. So if they're willing to undo it and enter into contract and they're willing to stick with one pharmacy, sometimes you can ask the pharmacy to not fill any prescriptions that come from anybody else. And they might be willing to do it. This is getting more willing to partner with the pharmacy because they don't want to be stuck in this process of enabling this behavior also. When I started doing this in the early 2000s, pharmacies were just looking to make sales. They'll sell it to whomever's asking, and doctors are writing prescriptions like it's going out of style. So times have changed. Then at the end of the day, you have to ask yourself, risk-benefit analysis, is it worth coming off? And you might have the unique patient where they've been on for so long, they're not willing, they're otherwise functional in every area of their life, the dose is not escalating, so that might be a different situation. Theodore.
I just wanted to ask a quick question about the Z drugs. What do you do to get people off of those? How do you feel about the orexin receptor antagonists? Do you think those are okay more long term? And I asked the question just because I've like had that patient that comes in, it's been on Ambien for like 20 years. And I've never really figured out completely what to do with that. So I just wanted to know what
Your
your
patient that's been on Ambien for 20 years likely doesn't want to come off the Ambien. Right. And so the conundrum is it's going to be really hard to build a case for them if they're not having any adverse effects. So now you're stuck with, well, we're not increasing the dose. The toxicology comes up negative. You are basically sleeping every night, functional during the day, not having any downstream effects. I may not fight that battle. If they are very motivated to come off and they say, I really want to come off of this, we can do it gradually. You can use gabapentin if they want a different medication. And then, but I'll tell you this, the first line treatment for a sleep disorder is not medication. In fact, I recommend you don't use medication as your first line if you're treating a primary sleep disorder. What I recommend is cognitive behavioral therapy, because that is the first line indication. And the way you basically do that, and we'll talk about this in the sleep lecture, but you have to really increase their sleep drive. And I'm going to leave it there because when we get to the sleep lecture, I'll tell you how we're going to deal with that. Erin?
I was actually about to lower my hand because my question was about why so many providers will prescribe benzos for sleep disorders.
Yeah.
Long term.
So I don't want to be cynical, but it's easy to prescribe. It works. The problem is once you get them on a benzo, it's going to be really hard for anything else to be as effective for their anxiety. It works. If you've ever seen that movie with, it was about the Purdue Pharma movie. Michael Keaton was in it. I can't think of the name of it, but it's been on. I think it's on Hulu. When these controlled substances came out, pharma labeled them practice builders. So what I have found, and I don't mean to be cynical or disparaging, but what I have found is practices will prescribe benzodiazepines because it requires a monthly follow-up visit for a refill. So if you look at the average out-of-network provider in Manhattan, who's probably charging anywhere from $600 to $900 a visit, not taking insurance. That's about the going rate, by the way. That's the going rate right now for out-of-network psychiatric provider, $600 to $900. Well, 10 of those a month will keep your overhead taken care of. And that's a very cynical view to have. But I cannot for the life of me think why someone as educated as this physician, many of them, would do this for a patient, and they work in psychiatry, where they have the 45 minutes to get to a problem, where they don't have the sufficient professional boundary to say to the patient, this is not helping you and I'm not going to enable your demise. I don't know why that's not there. Suffice it to say, it's not there. And for a lot of them, it's easy to prescribe and keep going. So I am telling you, as psychiatric nurse practitioners whose practice will be scrutinized every single day, and doctors will love to remind you that you're not a physician. And I am not a physician. I'm not nearly as dangerous. I'm not going to put you on a benzo for years, 4 months. This is not helping anyone. I'm going to first do no harm. And maybe I'm not the right person for you. There are 20 others out there that you can doctor shop to. They're really willing to write that prescription. So it's sad, but you're going into the field to do the work. Do the work. Get to the root cause. Have a relationship. Offer them something different. Build the therapeutic alliance. Inhalants, this one caught me by surprise because I was like, who's inhaling? We have all kinds of things. Well, there is a population out there that's inhaling and does not want to stop. And the problem is I can't test for this. It's hard to test for inhalants because they're fast. They're inhaled, they're in, you get high, they leave the system quickly, you inhale again. And what are they inhaling? Basically anything. Benzene, acetone, hexane, rubber cement, butane, propane, whipped cream, liquid air in the can, chloroform, halothane, nitrous oxide, you name it, they're inhaling it. And the problem with this is it has physical effects. It's altering your sensorium, obviously, but there's a condition that is called cardiac sensitization, where it can make the myocardium especially irritable. So there's a condition called sudden sniffing death. A huff in the wrong direction, essentially, of the wrong product, they have a sudden cardiac death event. Now, I don't know who this is going to happen to, but the reason they're doing it is that it alters their consciousness. The problem, of course, is when it alters consciousness, it can cause asphyxiation. Some other things include things like poppers. These things can cause a rush. And basically what they're looking for is brief euphoria, enhanced sexual sensation, muscle relaxation, and this becomes a way of life. I'm amazed at what people will spend on inhalants to just sniff this stuff. A couple major complications you need to look at are methylglobinemia, immunosuppression long-term, and there's a retinal toxicity. So I always used to say the eyes are the windows to the soul. A good ophthalmologist will tell you if you have diabetes, Wilson's disease, some sort of toxic condition. They look and they can see everything because it's highly vascularized and it's an end organ, so you can see damage quite quickly there. But suffice it to say, inhalants are more common than I thought. And the big danger, of course, is transient hypoxia, which, who needs hypoxic brain injury? The big thing you want to keep in mind, don't forget about the physical exam and neuropsychiatric findings associated with the various substances. So alcohol, you might see tremors, nystagmus, dysarthria, ataxia. Opioids, constricted pupils, which is meiosis. When they go off the opioids or in withdrawal, then you see the dilated pupils. So that's a good way to tell, are you intoxicated or withdrawing? Let's look at the pupils with respect to opioids. Cannabis, the injected conjunctiva. These are things you would document in a physical exam. You might order these blood tests as well. You can certainly check a height, a weight. I do refer people to dental because I realize most people with any sort of serious mental illness and substance use are probably not tending to their teeth as well. So dental is also one of those nice partnership healthcare provider relations that you can establish and connect with. And then, of course, with cardiovascular findings related to stimulants, you might have tachycardia, hypertension, arrhythmia, chest pain, etc. All of that can be picked up as well. I like a pulse oximeter, and I generally will listen to the heart and feel the wrist at the same time. That gives me a whole lot of cardiovascular information in one setting. There's not a lot of undressing, so it's okay to do in psychiatry. You have all taken physical assessment, so you are technically responsible for the physical exam, whether you do it yourself or you outsource it to primary care. Obviously, most psychiatric providers are not doing this. I happen to do integrative care because I do family practice and psychiatry. So for me, I tend to blend it all together in that respect. I know some of you in the course are doing the postmaster's component. So something to realize you can combine the two. Addiction is a very popular subspecialty in primary care as well. Let's take a look at this case here. This is a 22-year-old college student. And she's binge drinking, having blackouts. She's in academic decline, and there's a strong peer influence and family history. What stage of change would you say this person is when you think about the trans-theoretical model? And we'll get into that a little more, but if you're familiar with it, take a look at where she's at. What stage of change might she be in here? If you look at what she's coming for. She's referred by somebody, right? And she reports, I'm just partying like everyone else. Weekend consumption is 8 to 10 drinks per occasion. So she's binge drinking. Balam, what do you got?
Pre-contemplation. She's not even recognizing the problem.
Exactly right. She's in pre-contemplation. So if somebody's in pre-contemplation, what do you do with them? What are you trying to do? Yeah, good.
Help them see how it might be affecting their school life, next social life.
Right. All you're doing when someone's in pre-contemplation is you're simply raising awareness. This is not the time to start offering a plan of action because they don't even think they have a problem. They're just here because someone made them come, and I'm doing what everyone else is doing. So they're sitting in pre-contemplation here. So you have to be very careful what you offer, because if you are not meeting them where they're at, they're going to leave with you don't understand me, goodbye. Take a look at this case here. This is a case of a 78-year-old male with alcohol and benzo use disorder, falling cognitive decline, multiple prescribers complicating the care. In general, what do you think you might want to do here? And how might you coordinate with multiple prescribers? Thoughts? Go ahead, Kirsten.
Do we know the 12 medications he's taking?
Well, no, we don't.
Yeah, that
So,
would be sort of my first step is ask him to bring his bottles in, do what you had talked about earlier, look at what he's taken, how many does he have, where is he in terms of refills, and looking at the doctors, prescribers, and then maybe reaching out to those doctors to see, is this everything that he's on?
good, good. Velma.
Definitely doing that thing you said about making sure no other pharmacies are prescribing anything and getting him off of the uh whatever else he's taking. Yeah, anyway.
Right. So that's all good. And that's exactly right. You're basically going to meet him where he's at. You need to get everyone on the same page and stop having so many people work against you. So that's basically it. You're going to get on the phone and start dialing the pharmacy and the other prescribers to kind of arrange a treatment plan. Take a look at these presentations here. So you have a 28-year-old male with the ED with chest pain, agitation, paranoid thoughts after cocaine use at the party. You see his mental status exam, and now look at his withdrawal presentation. Same patient now, but he's 36 hours later, attempting to quit after a cocaine crash, and there's his mental status exam. So the cocaine stimulant intoxication withdrawal is on the left. And then on the right, you'll notice where it says opioid intoxication versus withdrawal. Take a look at those. So a lot of you here, I've said, worked in the emergency room. How do you guys differentiate intoxication versus withdrawal in the emergency room? Some of the ER people, please chime in.
Physical symptoms, tremors, seizures.
For who?
Oh, sorry. I guess I'm thinking alcohol primarily.
So looking at cocaine and opioids, how do you distinguish?
For cocaine, it could be EKG changes, tachycardia, hyperactivity.
Yeah. Versus that's for the intoxication. What about withdrawal? Because, you know, I don't think cocaine withdrawal is going to get a lot of attention in the emergency room as much as the intoxication phase. And likewise, I don't think opioid intoxication, unless they're not protecting their airway, is going to get much attention compared to the withdrawal phase. So you see how they're distinguished there. Obviously, with opioid, if the airway is protected and they're not able to, they're able to maintain, that person's basically going to need the tincture of time to let it wear off, and maybe they'll give something if he has withdrawal symptoms. Dominic.
Similarly to what you said, I think the opioid withdrawal, and both and the cocaine withdrawal, probably cocaine withdrawal goes under the radar the most, because like you said, there's not much that we are seeing. They're not making a big statement. They're not when they come in and they're intoxicated. It's very obvious what's going on. And opioid withdrawal, again, generally they'll come in and they'll say, you know, I'm dope sick. Like I need my methadone. I need this. I need that. Similarly with cocaine, you were saying, how do we know? They'll come in and if you ask them, they'll tell you. It's very open because they'll like, I use cocaine. Like, did you use anything today? And most of the time they'll say yes.
Are they asking you because you're going to give them some cocaine in the hospital? Do they think that?
No, I think a lot of times they'll come in and against their own will, they'll come in with the police or whoever it may be because they were acting erratically. And it's like, you know, why are you doing this? And they'll say, no, I'm fine. Let me go. I did cocaine.
Got it. That's exactly right. So basically, we only have one way to tell. And of course, toxicology is useful in those instances because maybe they didn't just do cocaine. And so you might then decide, oh, maybe I need to keep you because you're equally using benzos. And so maybe we have to worry about benzo withdrawal because those are very commonly combined together, uppers and downers. These are some commonly overlooked substances here, gabapentin and pregabalin, rising misuse rates. Again, it's misused and they're having the same downstream effects. But I don't get terribly excited over gabapentin because, like I told you, that reverse absorption that happens with the increasing dose. The Z drugs, zolpidem and the like, dependence often runs unrecognized. And then also over-the-counter cough medicines and the like, these also can be utilized. Antihistamines, dextromethorphan, the kids call it robotripping. Interestingly enough, dextromethorphan is now mixed with another antidepressant. I can't, Aluvity, I think it is. It has, that goes under that name because there's some antidepressant properties there. I don't know anyone prescribing it. It was popular for all of 3 weeks, I think. But suffice it to say, we are in a country where anything worth doing is worth overdoing. And if it can be abused, it likely will be. So welcome to the age of excess. Now, it's not new. We just have more things we can be excessive about. Now I'm going to switch briefly to process addictions. These are the behavioral addictions. Basically, we're dealing with repetitive behaviors despite negative consequences. So fill in your favorite repetitive behavior that can yield negative consequences. The most popular ones are things like gambling and gaming. But another one that comes on, and by the way, let me just talk about gambling real quick. This is the only one that's behavioral that's in the DSM. And this is important because essentially what we're doing is we're shifting a behavior into the domain of addiction medicine. There are no medications approved for this. Everything using to treat this is going to be off-label. But we're seeing behavior as an addictive substance because it triggers the same neurobiological pathway. So you basically have to meet 4 of the 9 criteria within a 12-month period. There's no mention here about the amount of money per se. It's just the behavior. So need to gamble with increasing amounts to achieve desired excitement, but doesn't have a dollar amount to it. This I'm finding very popular in my young 20-year-olds, 20 to 25. They typically come from affluent families. And my most recent ones have gambled from $500,000 to $1 million. And families have been covering it, and it's very hard to treat. The reason this is very hard to treat, especially in the affluent, is because everything is covered and there are no real consequences. So this gets to be very difficult. Because I'm at the point, it's like, well, why are we treating this? Who's bothered by this situation? Like, maybe we could just gamble legally. How about that? Let's not do the illegal gambling. Let's just gamble legally. It's legal. Maybe you'll be a professional gambler. Let's get good at it. So when you lean in that way, then they will tell you why it's a problem, because most people don't perceive this to be a problem so long as they're not encountering consequences, even though they may identify with all of this criteria. So this is quite difficult to treat. There are groups, support groups built on the 12-step AA model, like Gamblers Anonymous and the like. What I find difficult is people of various socioeconomic strata have a hard time doing these groups with people of very different socioeconomic strata. So I'm running into a difficult time finding my Wall Street millionaires and billionaires going to, say, people that have gambled it all away and are basically one step away from homelessness. The person one step away from homelessness, it's a financial situation. The person who's living in their penthouse apartment, it's not about the money, it's about the havoc they're wrecking on their life and the people around them. So that's the distinction. And so sometimes they have a hard time, but it can be useful to say, look, no one got here overnight. You know, $1 million is a lot of money. You can blow only but so many of those before you run out. And so, but oftentimes I have found that not able to hear it. Some off-label things, SSRIs and naltrexone are being used, but and NAC, but all of that, all of this behavioral stuff and any of these addictions require a ready willingness and ability to change on the part of the client. If they are not ready, willing, and able, there's not a lot that's going to happen here. So compulsive sexual behavior and pornography use, this is not in the DSM. My sex therapy research and therapy group says it maybe should be, but the argument is that we don't want to pathologize a healthy sex life. So if you happen to have a lot of sex every day, we don't want to say that that's a problem. But I think we could probably come up with a criteria very similar to gambling disorder or substance use disorder to quickly identify what might be problematic sexual behavior. But in general, the issue here is these uncontrolled sexual urges associated with shame and guilt and relational dysfunction. Again, no medications are approved for this. This is not even technically a disorder, but say that to the person who's got relationships falling apart, who may be contracting things, who's got a string of engaging commercial sex workers and the like. So this can definitely wreak havoc. What do you think the barrier would be to addressing care in a patient like this? Let's take insurance out of the equation. Let's say they can pay privately to get care or treatment for this, because there is a sexaholics group as well also. What do you think might be a barrier to dealing with this patient? Or how might you deal with this patient? Maybe some of you have encountered this. Shame. Yep, absolutely. Shame is a big one. That's common with most addictions. Go ahead, Irina. Yeah.
One thing I want to say about, I think one reason it may not be in a DSM, because a word sex addict is very much not abused, but in certain, especially religious group, it's being used as labeled for people who like step out of their marriage, for example, or are not.
Oh, that's very good.
Or in another religious canon, and rather than address it as a normal behavior, oh, he's a sex addict, that's why he cheated on his wife, rather than
as if that excuses it, right? It's like, oh, well, he's a meth addict, that's why he uses meth. Oh, he's an opioid addict, that's why he uses opioid. He's an alcoholic, that's why he uses alcohol. It doesn't excuse the behavior, but you bring up a very good point. The minute you label it, pathologize it, stick it in a book in which insurance generates a billing code and you can reimburse for it, does this suddenly now become a new disability that we're going to have to do accommodations for? Is this something? This is an interesting thing to think about. Why are we, in fact, if you look at, who is the guy from the 60s? I believe his last name was Zass, S-Z-A-S. He's the one that talked about how psychiatry is essentially pathologizing all of what we would say are maladaptive behaviors into a book of diagnoses. And we're taking away this concept of human agency and autonomy, and maybe we're trying to take away responsibility. That was his social argument. He was a psychiatrist also. I think he was out of Cornell, but he went into private practice and wrote several books. And but suffice it to say, it's interesting when you label a behavior as a disorder, I don't think that necessitates an excuse, because you're still responsible for your behavior. However, this, I think what will happen is it'll allow you to at least access care for the person that's ready, willing, and able to access care. So that's something to think about. In general, the treatments aimed at most process disorders or process addictions are a combination of cognitive behavioral therapy and various recovery models. Any medication is basically off-use, off-label. Gaming addiction is another one that's popped up. Same habitus as and social media and shopping disorders is another one. This is driven a lot by FOMO, fear of missing out, and you may get that in gambling as well. And when you start to see sleep disruption and the like, that's reducing physiological and psychological resilience. Now, there are some clinical integration behavioral addictions, so there's various approaches to assess for it. And, there's different questionnaires that you can utilize. But again, none of the questionnaires and screening tools are necessarily diagnostic. They are just that. They are screening tools and a way for you to open the conversation in a structured manner that you can then see if they're willing to engage with you. And this is the audit, which is a longer version for alcohol use disorder to screen for them. Again, non-diagnostic, just opening the conversation. The only ones that are really good clinical utility are the SIWA and the COWS. And so those are important because they require acute interventions. Let me just quickly go over the stages of change and motivational interviewing here. This is Prochaska and Di Clemente stages of change. When someone's in pre-contemplation, there is no recognition of the need to change. Ideally, they would progress along to contemplation where they, there's a problem, but I'm not sure what I want to do about it. So you know that the ambivalence is normal. Then they prepare to take action. The biggest thing people do is they mistake preparation for action with action. This is in preparation where they plan to make a commitment to change. I'm ready. I'm going to do something. I'm putting the gym clothes in the locker. I've planned the thing. I've thrown out the cigarettes. I'm planning. Right? Action is when they're actively doing the thing they said they were going to do. And then maintenance is if they've been able to sustain it for at least 6 months. Now, relapse is not part of the original stages of change, but certainly belongs in any discussion on addiction, because they say that relapse can be an opportunity for learning. Not a lapse is not the same as a relapse. And I'll tell you on the next slide about distinguishing that. But basically, if you compare the motivational interviewing techniques with the stage of change, where you're coming alongside and building that therapeutic alliance, you may be a lot more successful than just arguing with the patient and trying to fix them. Really, you want to come alongside and learn their motivations. Now, relapse prevention, this is interesting because this is not formally addressed, but there is a model by Marlatt and Donovan. It's a cognitive behavioral approach to identifying who is likely to relapse. And the biggest indicator is basically a negative emotional state for somebody in a high-risk situation who did not develop sufficient coping mechanisms. So 35% negative emotions, 20% social pressure, and 16% interpersonal conflict are the contributing values to what constitutes a high-risk situation. There is this phenomenon called the abstinence violation effect. This is basically a single lapse. Now, that single lapse can just be a single lapse if there's good self-efficacy and coping, or that single lapse can trigger a maladaptive cascade and go back to previous use. What constitutes relapse is very different. Is it a relapse if you go back to using but less than what you did before? Or do you have to go back to previous use to constitute a relapse? That's a debate in the field. I think if you go back to consistent use, that constitutes a relapse. But a single lapse, this is like, I'm on a diet, I've eaten 2 cookies, I feel bad. I either eat the rest of the cookies, that's a relapse, or you know what? This is fine. 2 cookies are not the end of the world. I will continue on my healthy eating pattern tomorrow. And then there you go. That lapse became a learning opportunity. And now you can identify what it was that set the stage for that to happen. You see, relapse does not just happen. Patients plan their relapse. They're not aware that they're planning the relapse, but they plan the relapse. They may leave a medication on the side. They may deliberately not follow up in a therapy session. They may deliberately go to where they were previously using before. I can just get close to the fire and not get burned. And so what happens is that happens enough times, and then you see the relapse ensue. So the main thing I want you to take from this is addiction is treatable with comprehensive evidence-based care. It requires a high degree of readiness, ability, and willingness to change. And it requires a lot of empathy and coming alongside. So the biggest driver of a successful outcome for any addiction treatment is going to be that therapeutic alliance, which is why that was the first lecture we gave in this class. And we will keep coming back to therapeutic alliance for every single condition that we go through. We ran a little bit over. If anyone has questions, I'll be happy to take them now.